Call this meeting to order. This is meeting number 46 of the Standing Committee on Finance. Orders of the day pursuant to Standing Order 83.1, continuing our pre-budget consultations 2014. Colleagues, we have two panels this afternoon, early evening, and I want to welcome our guests for the first panel. We have with us here this afternoon, we have the Canadian Doctors for Medicare, Mr. Richard Classe. Am I pronouncing that correctly? Classe?
Correct. That's correct.
We have from the Canadian Foundation for Healthcare Improvement, we have the President, Maureen O'Neill. From the Heart and Stroke Foundation of Canada, we have the CEO, Mr. David Sculthorpe. From Hope Air, we have the Executive Director, Mr. Douglas Keller-Hobson. And from Sunnybrook Health Sciences Centre, we have the President and CEO, Mr. Barry McClellan. Welcome to all of you. You'll each have 5 minutes maximum for your opening statement, and we'll begin with Mr. Classe, please.
Well, I'd like to thank the House of Commons Standing Committee on Finance for this opportunity to present on behalf of Canadian Doctors for Medicare. My name is Dr. Richard Classe. I'm a medical oncologist at the BC Cancer Agency in Vancouver and a clinical research scientist at the Research Institute associated with that, and a professor of medicine at University of British Columbia. Canadian Doctors for Medicare has an abiding interest in the evolution of the federal role in healthcare. As medical professionals, we are firmly committed to evidence-based healthcare policy reform. We advocate for innovations in treatment and prevention services to improve the quality, sustainability, and equity of our health system. We believe that our healthcare system can and should be improved, and we hope that today's hearing will play an important role in providing more equitable, high-quality, and sustainable healthcare from coast to coast to coast. As practicing physicians, CDM members see firsthand the disparity in care experienced by Canada's marginalized and multi-barriered residents. CDM believes that improving the care experience of our most vulnerable communities is both necessary and achievable. We advocate for action in 3 specific areas. First, in upholding the Canada Health Act. Second, in developing a new health accord. And thirdly, in improving access to prescription drugs through a national pharmacare program. And these have all been outlined in the 5-page brief that was circulated beforehand. Each of these reforms begins with strong, accountable federal leadership to enforce standards across the country and to improve the care for our most vulnerable populations. As part of its commitment to the Canada Health Act, the federal government must recognize that new forms of privatization, including user fees and extra billing, have emerged since the Act was passed in 1984. Some of these take advantage of legislative loopholes while clearly violating the spirit of the Act. These loopholes must be closed and violations must be penalized. An accountability framework that requires provinces to proactively regulate or investigate clinics for compliance with these laws is clearly needed to ensure that the CHA is upheld. Another area in which the federal government must demonstrate leadership is by establishing a new health accord. The absence of such a guiding document exacerbates current provincial disparities in health care, again with the greatest impacts experienced by vulnerable populations. Improving equity in care requires establishing a new 2015 health accord with improved measures for accountability and especially standardization of care across the country. We also must take some starting steps towards a national pharmacare program. Canada currently pays at least 30% more than the OECD average for prescription drugs. By offering first dollar coverage, a universal pharmacare program would generate savings of between 10 and 41% on various prescription drugs, representing a total saving of up to $11.4 billion per year in Canada. Moreover, a national pharmacare strategy would improve the health and quality of life of our most vulnerable residents. While 1 in 10 Canadians can't afford their prescriptions, amongst those without any supplementary health insurance, that number increases to 1 in 4. Inability to access medically necessary prescriptions results in decreased quality of life for patients, while increasing demand on hospital resources as their untreated conditions eventually lead to hospitalizations. At the provincial and territorial health ministers meeting recently in Banff, the ministers agreed to work together to reduce the cost of some 53 commonly prescribed drugs. This decision will result in over $260 million in combined savings annually. However, the capacity of the provinces to implement.
1 minute remaining. You have 1 minute remaining.
However, the capacity of provinces to implement pharmacare-like strategies are limited in the absence of a national formulary. Pharmacare expert at the CD Howe, Steve Morgan, cautions that any attempts to institute a national pharmacare strategy requires active leadership from the federal government. Canadian Doctors for Medicare is pleased to have the opportunity to contribute to this hearing. In conclusion, we recommend that the federal government close loopholes that allow for-profit clinics to violate the Canada Health Act, demonstrate leadership and vision by reopening the health accord negotiations with provinces and territories, and support the provincial and territorial health ministers' initiative to develop and implement a national pharmacare strategy. Thank you.
Thank you very much for your presentation. We'll now go to Ms. O'Neill. And Ms. O'Neill, I understand you're beginning with the video presentation. Is that correct? You are beginning with the video presentation?
No.
Well, the second panel. Okay, thank you. Sorry, I was mistaken.
Thank you. Good afternoon, Mr. Chairman. I'm Maureen O'Neill. I'm president of the Canadian Foundation for Healthcare Improvement. Merci de m'avoir invité.
Thank you for having me invited you this afternoon.
Profit organization dedicated to accelerating healthcare improvement. We play a unique pan-Canadian role in supporting healthcare innovation on the front line, bringing together teams from different jurisdictions to improve continuity of care, focus on patients and families, and increase value for money. We work with leading organizations like Sunnybrook down the table. These teams include patients and family members, healthcare providers, and executives. Nos travaux correspondent à la priorité du
And our work corresponds to the priority of the committees, which is to contribute to the health of Canadians, many of whom are members of vulnerable groups.
Is that we are helping to save healthcare dollars while improving patient care and health outcomes right now. But for our work to continue, we need funding in Budget 2015. Nous sommes à l'œuvre dans chaque province et territoire et nous menons actuellement plus de 100 projets sur le terrain. Plus de la moitié de ces projets sont des innovations qui ont fait leurs preuves et qui se répandent. Nous avons une forte participation d'organismes québécois. This year, we are spreading innovative ways of working, better care for people with dementia living in long-term care, and better support for patients with advanced chronic obstructive pulmonary disease, COPD. 1 in 3 long-term residents receive strong antipsychotic medication without a diagnosis of psychosis. We helped the Winnipeg Health Region use data and proven approaches to take 1/4 of their residents off antipsychotics without any negative consequences. Now we're supporting 52 long-term care homes across the country to replicate Winnipeg's success. Small investment, big savings, better care for patients and families. The second collaboration focuses on a huge driver of hospital costs, COPD. When people with COPD have trouble breathing, they and their caregivers rush to the emergency room. In Halifax, home visits, teaching self-management, and advanced care planning have reduced hospital use by 60%. That's a good idea worth spreading. À l'heure actuelle, nous aidons les équipes de 10 provinces.
At the present time, we are involved with 10 teams, in 10 provinces to adapt and improve their programs. These exchanges between regions and province are an opportunity for mutual stimulation and learning.
$1,000 from the private sector to leverage federal dollars in this program, and this will improve care for more than 11,000 COPD patients. The potential cost savings are huge. So once again, a small investment, big savings, and better care for patients and families. We're also working with First Nations, veterans, and Canadian forces. You can learn more about these initiatives in our brief, including pioneering work involving patients and families in the design and evaluation of health care. An independent analysis by Risk Analytica has determined that just 5 of the innovations we have supported over the past 15 years could generate well over $1 billion in annual savings through fewer ER and specialist visits and hospitalizations. KPMG recently confirmed this finding in an independent evaluation. Small investment, big savings, better care for patients and families. Dans le budget de 2015,
for the 2015 budget, we are asking for annual funding of $10 million over 5 years. We will obtain leverage for this small investment because we will find ways to reduce health care costs and at the same time improve the health outcomes and care for Canadians.
Many around this table. Thank you very much for your time.
Thank you very much for your presentation. We'll now hear from Mr. Sculthorpe, please.
Thank you, Mr. Chair and honourable members. The Heart and Stroke Foundation is a national volunteer-based charity led and supported by more than 140,000 volunteers and close to 2 million donors. The aim of the foundation is to create healthy lives free of heart disease and stroke. We do this through the advancement of research and the promotion of healthy living. We've come a long way since my grandfather suffered a heart attack many years ago. At that time, he was put on enforced bed rest and only allowed to sit in a chair upright after a month. Only 15 years ago, when someone had a stroke, they were transported to the local hospital in an ambulance with no lights or siren on, and were told there was nothing that could be done. Today, a stroke is treated as a medical emergency. The ambulance quickly transports the person to the right hospital, set up to handle strokes. Following an immediate CT scan or MRI, if a clot is present, the person is given TPA and is often able to leave the hospital within days with no significant disabilities. It is the $1.4 billion in research funded by the Heart and Stroke Foundation and the leadership of the Foundation and our partners that have made these changes possible. But despite an impressive 75% reduction in the death rate from heart disease and stroke over the last 60 years, every 7 minutes, someone in Canada still dies from heart disease or stroke. That's unacceptable. It amounts to more than 66,000 deaths a year. That's unacceptable. Heart disease and stroke are the leading cause of hospitalizations and the second leading cause of death in Canada. We clearly have much more to do. Despite the shocking statistics, further investment in cardiovascular research has stalled. That's why I'm before you today to seek a partnership with the federal government and our partner organizations to, 1, sustain Canada's leadership in heart disease and stroke research to improve health, reduce death, lower healthcare costs, and improve Canada's overall productivity. 2, to launch programs to reduce vascular dementia. And 3, to improve the health of Indigenous peoples. With regards to cardiovascular research, we're looking for an investment of $30 million annually from the federal government to match funds that we have committed. This federal investment would be managed in partnership with the Canadian Institutes of Health Research. What's the opportunity here? In addition to saving lives and improving Canadians' quality of life, this investment would create high-value jobs. 70% of the funds would go towards job creation. It would also help to attract and retain young researchers in the field. We're also working with the YMCA, the Alzheimer's Society of Canada, and the Canadian Diabetes Association to have the federal government help address the prevention of dementia. The connection between cardiovascular disease and dementia is undisputed. In older adults, vascular disease is implicated in 80% of people with cognitive dementia, cognitive impairment. An investment here would reduce the risk factors that impact vascular dementia and many other conditions. Delaying the onset of dementia by 5 years could decrease the prevalence of the disease by as much as 44%, reducing healthcare costs, increasing productivity, and improving quality of life. For this initiative, we're seeking an investment of $20 million annually. Partnering with the Foundation would also be consistent with the government's focus on healthy living and its recently released National Research and Prevention Plan for Dementia and the announcement made by the Minister of Health, Ambrose, last Wednesday.
1 minute.
Dementia-related diseases currently cost the economy an estimated $33 billion a year. This figure is expected to soar to $293 billion by 2040. Our initiative will combat this prediction. As a third initiative, the Foundation is also working with the Canadian Diabetes Association and the YMCA on a plan to improve Indigenous people's cardiovascular health. Indigenous people are twice as likely to develop cardiovascular disease and have a higher proportion of CVD risk factors. This simply can't continue, and we have programs that can help. We have been in discussions with Indigenous groups, and they're very enthusiastic about our commitment to work with them. We believe that an investment of $50 million annually will be needed to support locally based programs that build capacity and improve health. Mr. Chair, thank you. I look forward to the questions and discussions with the honourable members.
Thank you very much for your presentation. We'll now go to Mr. Keller-Hobson, please.
Thank you. Good afternoon. My name is Doug Keller-Hobson, and I am the Executive Director of Hope Air. I appreciate this opportunity to appear before the Finance Committee during the Budget 2015 consultations and to share with you our proposal for a very specific legislative change that would improve access to necessary health care services for low-income Canadians, regardless of where they live across Canada. Hope Air is a registered charity whose mission is to provide free flights for those who are in financial need and must travel long distance to reach specialist medical care. The only Canadian charity dedicated to providing this service coast to coast, Hope Air helps low-income Canadians of all ages who are suffering from a wide range of illnesses. Hope Air is not an airline. Rather, we are a lifeline for many fellow Canadians who need to access the advanced medical technology and specialists which are typically available only in larger urban centres across our country. Since its founding in 1986, Hope Air has arranged over 87,000 free flights for low-income Canadians, including over 7,000 flights last year and with over 8,000 projected in 2014. Hope Air's submission to this committee is focused and specific and can be enacted at little cost to the Treasury. Our budget proposal seeks an exemption from the air traveler's security charge for all flights being provided free of charge by a registered charity to low-income Canadians traveling to required medical appointments. The air traveler's security charge is a flat rate fee, currently set at $7.12 plus HST for a one-way flight to cover security costs in place at the 89 airports across Canada. This proposed change would cost the Treasury approximately $57,000 for 2014 and can be made by either revising or adding a clause to Section 11 of the Air Travelers Security Act. More to the point, for today's mandate of exploring ways to support and help vulnerable Canadian families, this change would enable Hope Air to provide an additional 230 flights per year for fellow Canadians in need. There is precedent for enacting a change such as this. Although the Act contained an exemption for air ambulance flights when it was passed in 2002, the ATSC still applied to other non-emergency medical flights. Recognizing the importance of excluding necessary medical travel from the ATSC, the government passed an amendment in 2007 making flights donated by air carriers to registered charities exempt from the ATSC. Since that time, Hope Air's business model has adapted to changing circumstances to include more private donations and funding partnerships. This enables us to directly purchase many more flights for our clients, but also making us still subject to the ATSC levy. The continuing impact of the current ATSC legislation is to restrict the number of clients we can serve. Almost half of Hope Air's flights are provided for children and their parent or guardian most of whom live in a household where the average income is close to their community's low-income line. This means that the vast majority of the families Hope Air helps devote a larger share of their income to food, shelter, and clothing than the average Canadian family.
1 minute.
Canadians who live in communities far from larger urban centres face many challenges in accessing the health care they need. They frequently face long-distance travel to get to their medical appointments at their own expense, and in winter risk dangerous long drives. This puts low-income Canadians at risk, as they often decide to cancel or delay treatment due to the travel costs. It also takes people away from work, school, family, and community for much longer than is necessary. Making the legislative change will benefit many Canadians by supporting families and vulnerable Canadians at a critical time when they are focused on improving their personal health. I appreciate your consideration of this issue for inclusion in the 2015 federal budget and look forward to your questions.
Okay, thank you very much for your presentation. We'll now hear from Mr. McClellan, please.
Good afternoon, and thank you for the opportunity to appear before you today. The growing global significance of diseases of the brain and mind, including dementia, stroke, and depression, is not a secret. The World Health Organization reports that depression is now the leading cause of disability worldwide, and that in people over the age of 65, stroke and dementia are the medical conditions with the greatest burden to society. With respect to dementia, over 500,000 Canadians suffer from this disabling condition, and the prevalence is set to double in the next 20 years. When the health ministers met at the G8 Dementia Summit in December 2013 to discuss how to shape an effective international response to the growing challenges of dementia, they committed to a call for greater innovation to improve the quality of life for people with dementia and their carers while reducing emotional and financial burden. The ambition to identify a cure or disease-modifying therapy for dementia by 2025, and increase collectively and significantly the amount of funding for dementia research. The vision of the Brain Sciences Centre at Sunnybrook is to approach dementia, stroke, and depression across the lifespan through a model of convergence, with research embedded in care, a model tested and proven with remarkable success at Sunnybrook in the Odette Cancer Centre and Schulich-Hart programs. At Sunnybrook, we already provide local, regional, and national leadership for these three major neuropsychiatric illnesses of our society. The Brain Sciences Centre at Sunnybrook will enhance our proposed transformative role. We are, of course, aware that the federal government does not directly fund the delivery of health care. This proposal is not about funding the delivery of health care. It is about creating an infrastructure that will enhance innovation and new discoveries that are relevant and beneficial to all Canadians. Innovation that will have national and global impact. Bringing our model of convergence to fruition through the creation of a Brain Sciences Centre will bring researchers together with specialists in neurology, psychiatry, neurosurgery, and neuroradiology to grow innovation. The Centre will promote accelerated discovery and application of new cures and disease-modifying treatments, including unique diagnostic imaging capacity, genome analyses and drug development, and image-guided interventions, including novel models of drug delivery. It will enhance networking. The Centre will be part of a national network with brain sciences and brain health centres across Canada, including the Brain Health Centre in Vancouver, enabling both economies of scope and scale and accelerating national capacity. It will advance the development of commercial partnerships and create jobs and help develop brain health-related companies. It will enhance care across the country and globe by developing and evaluating new models of care, and in so doing, protect vulnerable Canadians and their families. It will train and educate the next generation of brain sciences researchers and healthcare professionals, and it will provide international recognition to the Government of Canada for not only taking a lead role in recognizing the burdens of these debilitating ailments, but for taking demonstrable action to create a better future. The request of the federal government is to invest in the future for Canadians by contributing as close to $30 million as possible toward the estimated $60 million cost for this research embedded in care brain sciences center. The Sunnybrook Foundation is committed to raising the balance. This public-private sector partnership presents an unprecedented opportunity to mitigate the profound impact of the major illnesses of our time, now and over the decades to come. Thank you for your attention.
Thank you very much for your presentation. I'll just remind our witnesses to hear, you can hear both the translation with the earpiece here. I hope you all have it with you. Colleagues, we should have enough for 7-minute rounds, so we'll start with 7-minute rounds. We'll see how long we get with them. And we will begin with Ms. Davies for 7 minutes.
Thank you very much, Chairperson, and thank you to the witnesses for coming today. I'm the healthcare critic for the NDP, and usually I'm at the Health Committee and not at the Finance Committee, but I have to say that often at the Health Committee, when we raise questions about healthcare related to finance, they always say, oh, you should be at the Finance Committee, so I'm glad I'm here today so I can ask some of those questions. I'll start off by saying that I think the debate around healthcare in Canada is always a very topical issue. It's something that people care about deeply, they think about, but it's more than about healthcare. It's very much about a very cherished Canadian value in terms of the public healthcare system that we have, and that it should be accessible to everybody. It's a foundation of our Canadian society. So I'm very glad that you're here today. And listening to the issues that you've raised and having read the briefs, whether it's the health accords, whether it's affordable drug coverage, a prescription plan, whether it's brain science, dementia, research dollars, to me it really coalesces around a question about the federal role. And again, you know, the federal role is not just to sort of shovel money out of the door, although there's certainly problems with that, because we do have a lot of independent assessment that says in the long run the provinces will probably be shortchanged by about $36 billion. But it seems to me that the central question is recognizing that healthcare is a provincial delivery question, but there is a role for the federal government. And so I'd like to ask you, now that the health accords have ended in March 2014 and they've not been replaced, what do you see as the federal role? We can talk about those individual issues of dementia or drug coverage, but how will any of that happen unless there is a clear federal responsibility at the table and there is sort of a proactiveness to what goes on? So maybe Dr. Klesser, you could begin by just letting us know, what do you foresee needs to be done in terms of a new set of negotiations? The health accords we had previously were far from perfect. In fact, many of the things were never followed through. So certainly accountability is very important. So if you could sort of design, if you were at the table saying what would a new agreement look like, whether it was for a drug plan, whether it was for funding, what would that look like to you in terms of the role for the federal government?
Well, I think as stated in our brief, we feel that for any plan, especially we focus particularly on a pharmacare plan, to be successful, strong federal leadership would be required. And that would be to engage the provinces and to set the standards. We wish that all the provisions of the Canada Health Act and the Medicare Act be continued, and that means portability, accessibility, and basically equitable access to resources across the country. It's very difficult if you're dealing with individual provinces to actually assure that that occurs. So from our perspective, again, strong federal leadership to set the rules of the game and to set the stage for how programs would move ahead will be required. I do realize these will be enacted by the provinces, but given the kind of country we have in our federalist system, I think it is the role of the federal government to take a lead on this.
Okay, thank you very much. And if I could just follow up with Mr. Sculthorpe, one of your recommendations has to deal with a government investment for Indigenous people, and that's clearly a federal responsibility. And you talk about the partnership with the Heart and Stroke Foundation, Canadian Diabetes, the YMCA, and it seems to me that this is a very critical issue that's really sort of fallen off. Again, in terms of the federal role, how do you foresee that as needing some kind of overall agreement in terms of with provinces, territories, and First Nations? What is the federal role in actually guiding that? Because it's not just about the money; it's about actually delivering the health outcomes and having very clearly established goals. So, how do you foresee that happening?
We see the I'm going to speak specifically to this initiative, which is important for the First Nations and for all those groups. And we want to work with the federal government. They have invested significant dollars there, and we think that in partnership with us, we can help engage the communities that are interested in the programs that we have to offer ourselves with the CDA programs, the Canadian Diabetes programs, and with the reach of the YMCA. We have programs that we have been activating, if you would say that, with First Nation communities in many provinces across the country with very, very substantial success and returns. And we have picked those best in class from our initiatives that really get tremendous engagement with different bands and different communities. They're from greenhouses in very cheap and expensive greenhouses where they can grow fresh vegetables very affordably, to hypertension initiatives where we can actually show where we've reduced blood pressure, to education in schools. So we think that this partnership is very important because it takes a significant amount of money. It's a big investment, and it goes to areas where people are genuinely committed and willing to try and partner with us, and so it's not a cookie cutter approach. We go to each band and work with them, and they figure out how to tailor the programs where we have the science and the arms and legs to make it work.
You have about 10 seconds.
Oh,
so
okay.
Okay. Thank you very much, Ms. Davies. We'll go to Mr. Saxon, please.
Thank you, Chair, and thanks to our witnesses for being here today. Each one of you in your opening remarks highlighted some important issues facing Canadians' health and also facing the healthcare system. One of the common themes, certainly between at least two of you, is dementia and the looming problem with dementia and the potential crisis as the Canadian population ages. So my first question would be to the Heart and Stroke Foundation. Can you elaborate on the scenario that you highlighted in your summary, your submission to the committee?
Thank you. I would love to. So the linkage between dementia and vascular disease is undisputed. And in fact, 80% of dementia is vascular related. And the Heart and Stroke Foundation has been working in the vascular area ever since we started with cholesterol, hypertension, and so what we're doing is we're taking our prevention programs that we know prevent vascular disease. 80% of vascular disease is preventable, and educating Canadians that this is also similarly can prevent dementia, and that 80% of 54% of Alzheimer's is preventable, and 80% of the vascular dementia, because it's vascular, is preventable. People don't think in terms of dementia being caused by lifestyle or diet. And that's where we're trying to go. So working with the Alzheimer's Society and Canadian Diabetes and the YMCA, we can get this message out. The Alzheimer's Society is doing great work, and they are focusing primarily on research for a cure and then what happens if you have dementia, as well as prevention. But if you think about what Heart and Stroke has been doing for 60 years, we have been focusing significant amount of our effort, whether it's research dollars or advocacy or health promotion, in preventing vascular disease. And we have a very big footprint across the country with all of our volunteers and our health promotion specialists across the country, and major relationships with leading research institutions, being at hospitals and universities across the country, where we can get this message out and do our program that they've completely supported in our submission, the Alzheimer's Society as well as diabetes, to get this out to prevent dementia.
Okay, now your specific ask, which is specific to dementia, is $20 million, if I'm not mistaken. There's a number of different organizations that have asked for funding specifically for dementia. How can you assure us that there's going to be an avoidance of duplication? And how are you going to be coordinating with the other groups that are also looking into the cure and treatment of dementia?
Well, I've got two answers for that. One, we're partnering with the Alzheimer's Society on this prevention initiative, which is significant. They're the biggest. They're focused on Alzheimer's, and we're focused on dementia, vascular dementia, and those two universes cover most of it. So you're kind of going with the two biggies in that instance, and then we can go to route to market with the YMCA, our outreach, CDA, and also Alzheimer's. The second thing is there is a tremendous need out here. So I think if you look at our program, which has $2 million for awareness, $12 million for reducing hypertension, $2 million to get Canadians walking through active transportation, $2 million to educate around nutrition. When you parcel those down, they are significant dollars in the area of vascular dementia and getting the message out and changing behavior. But if there are other organizations doing it, that's good too.
Thank you. Chair, how much time do I have left?
You have about 2.5 minutes.
Okay, thank you. Then quickly, I'd like to go to Sunnybrook and ask you, how would what you're proposing for dementia complement what the Heart and Stroke Foundation is proposing?
Right, so first of all, I want to build on something that Mr. Sculthorpe has already covered, and that's that there's a close relationship between disorders like depression, stroke, and dementia. It's not well recognized, but if a person experiences depression, their risk of stroke and dementia increases. If someone has dementia, the risk of stroke and depression increases. These are closely related. So there does need to be a very coordinated approach to dealing with diseases of the brain and mind. With respect to working together, we cannot, in this environment, afford redundancy. We cannot afford to have a situation in a country like Canada where we don't know what's happening in Vancouver and work at Sunnybrook is not being shared nationally to make sure we get the best future bang for our buck. Our proposal, in fact, is building on networks that already exist. I highlighted the very excellent center that's in Vancouver right now. There's strength in Calgary. There's strength in other centers in Toronto. And being successful in treating dementia, specifically to go to your question, is dependent on us being coordinated, having a network of researchers, and ensuring that there's a strategy that's known by all.
Okay, thank you very much. And very quickly,
45 seconds.
Thank you. I'd just like to ask Hope Air, what are the main challenges that you're facing right now? And will the increase in fees for carry-on bags, check bags, and that sort of thing also affect what you're trying to do?
Thank you. Increased fees always do, and hence why we're asking for the specific legislative change here that will actually reduce fees. We partner with all the airlines. They're very close relationships, and we're working on seeing whether, just as we're advocating today for assistance here to help vulnerable families, I'm doing the exact same with our airline partners. So whether we can get them to waive certain fees. Again, it's sometimes our donors pick up additional costs if the families themselves cannot. So today's request here, though, is very direct, and will certainly add more flights.
Thank you. Thank you. Thank you, Mr. Saxton. Mr. Bryson, please, you're up.
Very much, Mr. Chair. And Mr. McClellan, you've spoken of the potential of this Brain Sciences Centre in terms of breaking down barriers and creating a more collaborative platform for research. I would add to your list as well the work being done at Dalhousie with the Dalhousie Medical Research Foundation and the Irene MacDonald Sobey Chair for Alzheimer's Research, Sultan Darvish, and some of the work done by Dr. Kenneth Rockwood. Are there other barriers to collaboration in terms of this kind of research, perhaps even issues around commercialization and ownership and IP? Are there other areas, in addition to direct funding of your initiative, are there other areas we should be looking at to break down the barriers that may be impeding collaborative results?
So first of all, I will acknowledge that there is significant strength in Eastern Canada as well, and specifically Dalhousie, and our researchers right now are working with teams there collaboratively. So I don't want there to be a message left today that there is not existing collaboration in our country. With respect to barriers, one of the approaches that's used at Sunnybrook that we believe is a model that others should emulate is treating those with disorders of the brain and mind together. So helping to destigmatize mental illness is a major undertaking right now in our country. And by taking individuals who have depression and having them in the same clinic area as those who may have dementia or stroke or other diseases of the brain is a major step forward. And we believe that that cooperative model within organizations is important. I've already mentioned the importance of networking to make sure that we have collaborative research taking place not only across the country but across the world. With respect to commercialization initiatives, we're starting to make progress in certain clusters across the country. We very much favor the cluster environment where we can bring together those with public and private sector expertise and interest. And we believe that by having a strategy around disorders of the brain and mind, that we'll be better positioned to be able to capitalize on commercialization opportunities, as I mentioned, growing jobs and companies.
Thank you very much. Maureen O'Neill, welcome back to the committee. Your funding's running out, and you have, according to your researcher submission, that 6 of your projects have reduced health care spending in the provinces by more than your total budget between 2006 and 2013. Is there another organization in Canada that's doing what you're doing today in terms of developing this research and sharing it with the provinces?
Thank you very much. No, in fact, what we're doing is actually not research, but really working with people on the front lines and helping to bring evidence of what does make a difference, both to them, but more importantly, bridging the divides across provinces, because Canada has both a great strength and a great weakness in that primary responsibility for health care is with the provinces, but we have very few vehicles for innovations at the provincial level in delivery of care to be shared across the country. What we are able to do is provide support to teams who are juried in, who want to share in particular areas to get the kind of assistance that is required, and also just the opportunities to share one with the other.
Disproportionately important for smaller provinces that don't have the bandwidth to garner this sort of best practice model.
Exactly. Very important. So, for example, in the Atlantic, all 4 provinces agreed that they would work together to look at ways of improving the care for people with chronic conditions. COPD, diabetes, mental health, etc. So 10 regional health authorities are working together. I think this is a first that the 4 Atlantic provinces agreed that they would combine to look at doing things differently, to find better ways of actually delivering health care now. So this is delivering health care in the here and now. It's not as adventurous as what we're hearing about from further down the table on looking ahead, but it is dealing with problems that people have right now and helping put into place solutions that we know about right now.
Thank you very much. Mr. Sculthorpe, for the Heart and Stroke Foundation funding you're seeking to support Indigenous people's health initiatives, what sort of return, given that the federal government's responsible for overall investments in Aboriginal and First Nations health care, and we can pay now or pay later, have you done some analysis of what kind of savings to the federal government this $50 million per year will render in the future?
So on this program, no, because the suite of initiatives that we would be bringing to the communities to pick and to massage to make it work for their needs and their desires will be slightly different in everyone. But I can tell you that when you get into the programs that we have today, so the hypertension program where we drop the blood pressure by a significant and statistical amount, it does reduce the healthcare costs and the death rate over the short, medium, and long term going forward, and we have all those numbers. We also know that coming out of the BC program with the greenhouses, that the quantity of fresh vegetables that's grown and available goes up significantly. So on a program-by-program basis, we know.
Okay, thank you. Thank you, Mr. Bryson. We'll go to Mr. Keddy, please, for your round.
Thank you, Mr. Chairman. Welcome to our witnesses. Very good discussion here today, and lots of questions being raised. To Mr. Keller-Hobson with Hope Air, you're the only registered nationwide charity that provides free flights for individuals who cannot afford that cost. I think you stated it's somewhere around 85,000 free flights since 1986. Congratulations on that. And I think most of us around the table are sympathetic with your ask. I'm not just certain how we can drill down to find a way to do it, whereas you're looking to really get around the air traveler security charge, $7.12 a flight. It's impressive that would give you a lot of extra flights across the country, an additional 230 flights, I think was the number you used. But you know, it would be a legislative change, but how can government do that and then treat one charity different than another?
Thank you.
You need to help us.
Yes, and I guess I go back to when the legislation was implemented. It was clearly established at that time that vital medical flights were to be exempted. That was always the spirit of the legislation. It caught up in 2007 with the next amendment when it was really discovered and advocated that Hope Air was not an air ambulance service, but still was vital medical appointments. And now we're looking at it again more than another 7 years out. And I guess I take the view of the intent and spirit of the legislation was very clear. It applies to all Canadians in that scenario through charities. And it's time for us always to continue to look at our legislation and keep up with changes in society. And here Hope Air has changed its business model, considerably grows more. And we put a considerable amount of money back into the airline industry through our purchases. So a simple act like this will, I think, deliver good results.
Thank you. Thank you for that. To the Heart and Stroke Foundation, you know, you put some numbers forward that the healthcare cost of heart and stroke and dementia and other similarly related diseases are somewhere in the cost of $35 billion per year, rising to somewhere around $200 billion by 2040, which is a frightening number. You know, you've got a great reputation and a good record. You know, 75% decrease in heart and stroke deaths. How do we, and I think a fairly reasonable ask, but how do we meet that ask, and how do we seek out partnerships from business and the provinces as well? Have you done that, or is that a possibility?
Thank you. We're a not-for-profit. We raise all of our money door to door, jump rope for heart, corporate partnerships, major gifts, direct mail. We work very, very hard on building corporate relationships. We have just unified as one foundation across the country in 2011 to enable better partnerships with national corporations, because our relationships were all provincial, and to become much more efficient and effective and have more mission impact. And we're seeing tremendous results from that. So we do believe our corporate support will grow, but it's a very small amount relative to what every Canadian gives to us. And it's, as I said in my opening address, almost 2 million Canadians donate to us, $40, $50, and a few give us a lot more money, but it's a small part of our fundraising.
Thank you. I guess it's the immediate cost versus the cost coming in the future if we do nothing.
When you get into the prevention business, that's always the debate that we're faced with, is do you spend $1 now to save it over the long term? And we believe in the prevention area of dementia, when you see those numbers, you can do nothing but make the choice to try to prevent the disease today, because those will swamp us in the future. And we know the issue and concern. My father had Alzheimer's for almost 10 years and passed away, and we know how much strain and stress that puts on a family and society.
Very quickly, Ms. O'Neill, you know, you're looking for $10 million over 5 years. You're seeking to find ways to improve health care, and I think that's a noble idea, and there's room to do it. One of the frustrations I have as a member of Parliament is the lack of coordination, and you mentioned the 4 Atlantic provinces are starting to work together. Good for them. It was a long time coming. But the lack of coordination amongst the provinces on things as rudimentary as one simple pharmaceutical buy for all provinces and all territories. Like, what holds that up? Why can't we do that in Canada?
Okay, just a brief response, please.
That I don't have the answer to on pharmaceuticals. I think Dr. Klaas is working hard on lobbying to have that happen.
Yeah.
You want Dr. Klaas to respond briefly?
Absolutely.
Just very briefly, please.
Very briefly, I think the problem has been that a lot of these activities have been siloed in different healthcare jurisdictions, and there is no real reason why it can't happen.
Okay, thank you. Thank you, Mr. Keddy. Ms. Caron, pour 7 minutes.
Merci beaucoup.
Thank you very much. I have a question for you.
Mr. Klasa, in your presentation you said that there are several gaps in the Canada Healthcare Act today which have not been addressed by the federal government or by provincial governments. Can you give us examples of these gaps or weaknesses in the Canada Health Act?
The majority of those have concentrated, I guess there's two different parts to that question. The gaps in the Canada Health Accord have to do with the different jurisdictions, provincial jurisdictions, and their ways in which the funding comes to them currently. So at the present time, and I'm not an expert, but my understanding is that with in the current system, the funding comes on a head count. Basically, provinces that are growing with growing populations tend to get more money than those that do not have that growth. So that just as a simple calculation tells us that in those provinces that perhaps don't have as much growth, where one might suspect there may be more vulnerable populations, which is what we're discussing today, the amount of relative funding will be less. In the previous set of accords, my understanding was that there was more thought given to how that money was apportioned. So that's one example of that sort of thing.
I'd like to come back to the issue of federal leadership when it comes to health care. Of course, this is an area of provincial jurisdiction. We can all agree on that. I put the same question last week to the president of the Canadian Medical Association. How can the federal government play a leadership role when the provinces are in charge of health care? Second question, quite similar or in parallel to that, the provinces themselves do not necessarily seem, there doesn't seem to be a lot of coordination between the provinces. You did give an example in your brief which dealt on the Pan-Canadian Pharmaceutical Alliance, but otherwise there's very little coordination between the provinces. Do you think the federal government could help the provinces to share best practices, and can it play a visionary role when it comes to providing healthcare services?
The federal government should have a major role in doing this and providing leadership in many initiatives. So the issue again is that provinces are somewhat siloed and separated in terms of how they have traditionally dealt with their healthcare issues. What one would hope from a federal government in our system is leadership that maintains the actual provisions of both the Medicare and the Canada Health Act. And that does provide and did solidify to some extent this idea that access to care would be equivalent across the country and that there would be portability from one province to another. It seems to me that without federal leadership we can't even begin to discuss that, because then we have each province arguing one-on-one with each other about how to proceed. So I don't see that there is any lack of a need for federal leadership in this debate whatsoever. What is necessary is a strong unifying voice that can help the provinces to each see the strengths that may be present in different jurisdictions. And there are strengths, many strengths, that are present in one jurisdiction that are not in another. And the federal government could help, the federal policymakers could help to point that out and to allow provinces to come together and actually agree upon standards.
Thank you very much. Perhaps one way this federal leadership could apply would be through a certain strategy. I will come back to Mr. Sculthorpe and McClellan and maybe back to you after that. So you are the fourth and fifth panelists in the last couple of weeks who have told us how important it is to apply concrete actions, or rather to say that the federal government should play a concrete role in the development of a strategy on dementia. We have an MP, Claude Gravel, who's particularly interested in this issue. Again, how can the federal government play a leadership role in bringing together the provinces, for instance, to create a strategy on dementia, or on finding solutions to this problem when, again, provinces are responsible for would be responsible for applying a strategy? How can the provinces and the federal government work together productively to achieve a concrete result?
That if they pull together an action plan done collaboratively with the provinces, it would go a long way and set the vision for the future.
And if I could add, an investment in infrastructure, which will help to guide the strategy, which will be a national strategy, bringing together hubs from across the country, will go a long way to building the innovation and the changes we need in order to actually implement the innovation. Innovation is one part. If we actually don't implement and actually make the changes, we're not going to see, better care for Canadians in future, whether it's dementia, stroke, or depression. So I do see that an investment in infrastructure will, in fact, help us to get to that point.
Monsieur Classa, pourriez-vous me donner une...
Could you give me a specific measure that the federal government could do as a federal organization to help initiate strategies concerning dementia or to help the elderly?
Can address the issue of dementia, but certainly in terms of the elderly in general, and there are many experts here on dementia, but in terms of care for the elderly, one of the major issues of our time, perhaps it's coming into its time now, is that we have to shift from a Medicare system designed 40, 50 years ago to deal with acute illnesses and hospital-based care, when the average age to which people lived was in the 60s, to one now where people born today are on average going to live to be 85. And many of the acute diseases are being well taken care of, but we are making out of acute disease chronic conditions. And those demand care of a different sort. And that care is now moving out of hospitals and into communities. And one role the federal government could have is to, and should have, would be to, to embrace this and to encourage, to give funding and to encourage ideas that actually move the model now towards one of more in the way of community-based and home-based care. And I don't think that's a surprise to anybody around the table.
Okay, thank you. Thank you. Merci, Mr. Caron. We'll go to Mr. Allen, please.
Very much, Mr. Chair, and thank you to our witnesses for being here. Ms. O'Neill, I'd like to start with you. I'm not as familiar with your organization as I read your brief, but what is the size of your organization? How do you work? Do you work virtually, or how does can you briefly tell me how that happens?
Certainly. It's a small organization, 40 professional staff, a board of 9 people who include a couple of deputy ministers, one of Alberta, one of the Northwest Territories, the Associate Deputy of British Columbia, former head of the Ontario Hospital Association, that kind of person, the person who in Nova Scotia is charged with the incredibly politically delicate task of reorganizing a number of regions there into one. So a board that is heavily endowed with people who have direct frontline experience in the provinces in managing healthcare, a staff who are professionally competent, and we work through often through use of ICT. So we run webinars. Our collaborations combine online learning with face-to-face meetings. We back it up. We've got a very strong capacity to assist the groups with whom we work to develop indicators and measure their performance so that they are able to evaluate whether the interventions they're making are actually making a difference. The benefit of bringing groups together from across the country, usually working at a sub-provincial level with health regions and hospitals, is that they have an opportunity to learn what is going on in other jurisdictions, because policy frameworks in each province are slightly different. I must say that our organization is one of the few that works across the country that has always had very strong participation from institutions in Quebec going back 15 years. And this might be for some organizations who are participating in programming the first time and maybe the only time that they've actually sat down with colleagues from Quebec.
Just extending on that, you've said in your brief, you said a recent analysis demonstrated that if just 5 of the innovations CFHI supported were implemented across 50% of the healthcare systems in Canada, they could generate more than $1 billion in annual savings. And so when I look at that, I'm very intrigued, because even though you said you're not as adventurous as the others, to me, getting the best bounce for a buck in healthcare means the basic blocking and tackling. So with that in mind, are some of those 5 and those 8 that you've listed as the most effective CFIHI supported innovations?
Yes, exactly. And you would be surprised at how simple some of these things are. We were chatting before the meeting about how simple changes can make a big difference. The challenge is that they are shared and that they are taken up. So, for example, I talked about the approaches to COPD, which will move care outside of the hospital into the community with proper supports. That alone is a big saving. That keeps people from going to emergency, because by keeping people out of emergency, you are providing care that is good for people but is less costly. And other things, doctors' offices using open access and being available more with longer hours keeps people out of emergencies. There's a whole bundle of things. Canada has been very slow to organize its emergency differently, and we have also been very slow in providing appropriate funding. I'm talking about the provincial level, providing appropriate funding outside of hospitals. It's really a bit of a mishmash out there at the community level, and that's where we have to go. But it is true, and we've documented very well how small interventions can make a surprising difference in expenditures. Now, this money never goes back to anybody. It shifts somewhere else in the healthcare system, but hopefully it shifts to somewhere more appropriate.
Is this because of the silos? I guess the barriers to implement kind of, difficult to work together, and you have the spread initiative. So I guess I'd just like to understand those barriers to implement. If it seems like a no-brainer, $1 billion, I mean, why don't we go after it? And if that's the case, does your organization receive any funding from the province, because they're a major benefactor of this too, because our provincial tax dollars are going into this?
That's right.
So are they a partner in the funding
Yeah,
of the organization?
they are a partner in as much as it is teams within their provinces who are working on these innovations and working to share them. So hence it's the labor of people in these institutions who are making the changes, and so in that way the provinces are indeed assisting greatly. But I do not feel we are where we ought to be in ensuring that there's an understanding of how you move from, say, in Manitoba, 52 long-term care homes, or sorry, not 52 in Manitoba, across the country, 52 long-term care homes doing this, and then the work that we have to do as the kind of intermediary is really do the convincing work to put that information before provincial people to say, look how this has spread. That happened in Manitoba. After the first personal care home used a different approach to dealing with long-term care residents with dementia, who had been overprescribed antipsychotics, the province, looking at that, said, okay, now we're going to spread it all across Winnipeg, and now we're going to work on spreading it across the province. Similarly in BC, in another very interesting project that reduced the time between for a patient between seeing a GP and seeing a specialist, they're now working on spreading that across the province. So provinces are key in taking up the innovations in healthcare delivery, and our challenge in what we do in working with the people across the country is then also working with them in working with their provinces and moving things along. But why doesn't it happen? Because people get used to doing things a certain way. and they continue doing them a certain way. The economists call it path dependency, and that's what we see operating all the time.
Okay, thank you. Thank you, Mr. Allen. We'll go to Mr. Rankin, please.
Thank you, Chair, and thank you to all the witnesses for coming today. I'd like to start with, if I could, with Dr. Klasa of the Canadian Doctors for Medicare. First of all, I want to thank your organization for its passionate support of publicly funded health care in Canada. You had 3 points, I think, in your very short presentation. The first was the desire that we uphold the Canada Health Act. Second, that we renew the health accord that's expired. And thirdly, talk about a national pharmacare program. I'd like to talk about each of them, but you mentioned in your remarks what you called, and I quote, legislative loopholes that violate the spirit of the Act. And then you talked about new fears of privatization. I can't help but thinking that you may be referring to the federal government's apparently lackluster support of the Medicare program in the Cambie Street Clinic, Dr. Day's clinic in Vancouver. Is that what you had in mind? And is the federal government there aggressively supporting our Medicare system?
Well, the case that's before the BC Supreme Court now involves a suit and a countersuit that basically involves the provincial healthcare authority. And the main protagonists here are the Cambie Surgeries Corporation, the provincial government, PHSA, in terms of the Ministry of Health. And then there are interveners such as Canadian Doctors for Medicare and the BC Health Coalition who have that status to inform the discussion. The federal presence in that particular argument has been less than obviously all the other players. And it is at this point, as far as I can tell, a provincial jurisdictional matter. But the crux of the matter is that there needs to be some sort of enforcement of the Canada Health Act if indeed we have a Canada Health Act. And the issue has been that there are providers of private for-profit care across the country that have, it would appear, or it is alleged, abused the system and inappropriately billed. And that is in the public record. There was an audit done of the Cambie Surgeries Clinic. The question is, what is the power and what is the power that will be used by the federal government in response to this? Supposedly, the Canada Health Act says that if a jurisdiction is improperly using the resource, then those tax dollars that were spent, let's say it's overbilling or double billing or extra billing, and if any of that came out of billing on top of what the province was paying, of which a proportion is coming from the federal government, then we have a right to reclaim that money. And there's been no attempt made, federally or provincially, to actually enforce those provisions.
So it's a lack of enforcement by the federal government that has led you, your organization, to appear as an intervener in that lawsuit to defend the Medicare system.
It certainly is one of the things. I mean, we are there because we believe that the Medicare system deserves to be protected, but also deserves to be changed and reformed as is required by the times. So it's not as though we're for a static Medicare system of all things going on as before forever. It's not true. But what we do want is to preserve, not to throw out the baby with the bathwater here. I mean, the majority of what the Canadian healthcare system can deliver, it delivers very, very well. There are other things that need to be dealt with. But a solution is not to have more in the way of private care, and that's detailed. Why is detailed in the brief. Basically, just to cut to the chase, what happens is you withdraw much more in the way of resources from the public system when you set up a private system.
And develop a two-tier system by stealth.
Yeah. It seems counterintuitive, the idea being, for those who propose it, that you can take people waiting in line who have resources, move them into the private sector, get them off the rolls. That'll make both systems function well, and the public system will be more efficient. But it's not true. Wherever that's been done, and we cite a number of documented situations where that's happened in other jurisdictions, Australia, New Zealand, and in Europe, what happens is you move a whole lot of resources, physicians, nurses, physiotherapists, out of the public system into private for-profit care. And the result is, for those who can afford to pay, and our vulnerable populations certainly can't, those people will get care sooner. But for everybody left in line in the public system, the wait gets longer.
Well, thank you, and thank you again for your organization's intervention in that case. The third thing you talked about was pharmacare, and I understand 1 in 10 Canadians today can't afford the medications that have been prescribed to them by physicians. I understand Canada is the second worst in terms of drug costs in the OECD. You said you called for federal leadership. You said it needs a national formulary for your pharmacare reform to take effect. Could you elaborate a little bit on what that would mean, a national formulary, and how you see the pharmacare strategy unfolding?
Certainly. Thank you for that question. In essence, what we've looked at, and a number of other organizations have now looked at and agreed with us about, including the CMA, is that we are overpaying drastically in terms of our drug costs. Part of that has to be where we're located on the planet geographically. But the other part of it has to do with simply not having a large bargaining unit to be able to actually cut a better deal. There are ways, if provinces can get together and do that, and we do that. At the cancer agency where I work, we essentially have pharmacare for all drugs that treat cancer. We negotiate for the whole province for those drugs. Now, we would be much more efficient and we could cut a better deal if we were all negotiating for the entire country. And similarly, it is a saving of scale. If we can come to the point of being able to negotiate for all of the drugs that are necessary, the pharmaceuticals necessary, to treat a population base of 35 million, we simply have more power to be able to deliver more for less.
You referred in a footnote in your actual submission to the work of Dr. Marc-André Gagnon of Carleton, who shows the tens of billions of dollars Canadians would save if we had such a pharmacare program.
It is a huge amount, and again, it is quite shocking, just if you look at the figures and the numbers, how much more expensive certain drugs are here than in other jurisdictions, and that's detailed in the brief.
Again, Dr. Claassen.
Thank you, Mr. Rankin. And now we'll hear from Mr. Van Kester.
Thank you all for coming. It's a great discussion we're having here. And Dr. Claassen, I'm going to keep on going with you. It's great to hear somebody that's in the medical profession who has firsthand knowledge and I guess has a bird's eye view of what's going on. It must be frustrating at times too to see how but I think in essence, and we all agree that the healthcare system that we have is one that has to be preserved. This government has provided more funding than any government. As a matter of fact, I believe it's a 60% increase, $20 billion since we formed government, and there'll be a $32 billion this year. How has that helped? Can you maybe talk about your ability as an organization to do its critical work? How has that helped you?
How specifically the funding helps?
Yeah.
Well, again, I mean, funding is necessary to deliver the services that we deliver across the country. And there is no question that our population demographics are shifting somewhat. And this requires perhaps a modicum more spending. But that really isn't the big issue. To me, the big issue is the distribution of that spending and how we're using those dollars. Innovations are never cheap. New drugs in cancer tend to be very expensive. And fortunately, they actually do prolong people's lives these days. So the question as a society that we have is how we're going to distribute the money and how we're going to spend for the best outcomes. So if your question is the extra funding that's being put in or the funding being put in by the federal government something that is obviously a good thing and used well, the answer is yes.
I want to go a little further, so the issue isn't so much funding, because there seems to be, and I don't want to pick on anybody here because I think everybody does great work, but I think most members of Parliament can testify to this, that as we are visited, especially those that are on the Finance Committee, visited by the different organizations, there seems to be a lack of coordination It's been brought up in a number of other questions that possibly we need to coordinate a little better. If you were king of the medical world, how would you, I guess, coordinate heart and stroke, mental health, all the others? What would are we doing that right? And I'm going to give them a chance to defend themselves. I'm not here to criticize them either, but there just seems to be that lack of coordination. And you want to comment on that?
Well, one can set up coordinations, I guess, in different ways. I'll let my colleagues speak to their areas of expertise. In mine, if I could do it all my way, then I would say if we had a national cancer program as opposed to just provincial cancer programs, then we could be more efficient, take the best innovations that are present in each province and spread them across the whole country, and deliver uniform care that Canadians deserve at the very highest level in that way.
Would you close cancer research centers possibly in one province in another if they did better work, or if they're more advanced or had better equipment or?
I don't think that would be the approach. I think the approach would be to bring people up to speed. In all provinces, there are pockets of expertise. There are areas of expertise. Some provinces have a little more than others, but there is expertise in every part of Canada. And here the idea would be to build upon that expertise and to really exploit what is being done much better in one province, and that then could be translated to another. And we've done some of that even in our own work, where we've talked to other provinces and said, you know, here are all our protocols on the web. We put everything up on the web. This is how we treat every patient with this cancer in this province at 5 cancer centers and 75 smaller outlets.
Put you on the spot, this one.
Oh, I better make sure I hear this one right.
All right. Now if for instance, Mr. McClellan were to get the jurisdiction of or would have a research center to work with mental disorders, would you possibly suggest that Heart and Stroke then would fund him and raise the money for that? Is that a better approach, or should we keep on doing what we keep doing, which is let all these other different organizations do basically, you know, I know it's not the same work, but it's trying to achieve the same thing?
I think it's important to have different approaches to the same problem, because unfortunately we actually don't know, because we are involved in research. The reason we're doing research is because we don't know the answer. So preconceived notions of how to go ahead sometimes turn out to be wrong. I think that different approaches from different jurisdictions and from different groups with expertise that spans a much larger spectrum is what I would do.
Okay. I guess I'll go with Mr. Sculthorpe.
You got 1 minute.
Just very quickly then, as an organization, you've identified a number of things to stop. You've slowed down heart disease and stroke. And now you want to expand that to First Nations. If we know what causes it, what exactly do you want to do within the First Nations groups to implement what you know already causes the exacerbating problem?
So it's a great question. On the last question that you talked about, I mentioned we've unified, so we are now all one. We are looking at best practices that go on in each province and sharing them across the country, getting rid of our duplication. And we've formed alliances with the top 20 leading research hospitals and universities across the country, and we're committing $30 million to them. One of them is Sunnybrook, one of the best in the country. We would do the same thing with, we've taken what we've done in BC, Manitoba, and Ontario as best practices of programs that are already very impactful, and we would offer them to First Nations. And all the different communities, the Innu, the Métis, okay, on reserve and in urban communities with our partners of CDA and the YMCA.
Okay, thank you. Thank you very much, Mr. Van Kesteren. Mr. Adler, please, final round.
Thank you, Chair. thank you all for being here today, and thank you for all the great work that you do across the country. I do want to focus my line of questioning on Mr. McClellan. At the end of this process, what we are doing here is prioritizing and assessing. There's been so many worthy causes, and we can't, of course, fund everything as much as we'd like to do that. Now, you spoke about creating a center whereby disorders of the brain and mind would work hand in glove with each other. Could you please explain in very layman's terms what exactly that means, and is that being done now at Sunnybrook? And thirdly, can you give a concrete example of where of an example that stands out in your mind where that has just a good example of that process taking place?
Thank you. So I'll start with, I think, what was about the third part of your question. It is happening right now. And the context for, I believe, your question and the last few that have been put to other witnesses, I think really comes down to return on investment. What is the best use of dollars in order to get the greatest impact? And in support of what others have said, I believe the investment should be selective. That doesn't mean only one center in the country, but it means that the investment is made strategically, that it's made into centers where there is expertise, where there's an opportunity to grow, and then the end result will be maximized by having networking and coordination. With respect to what it means to actually have disorders of the brain and mind treated together, our brain sciences program at Sunnybrook is unique. We bring psychiatrists together with neurologists and neurosurgeons and those who specialize in imaging, as well as the non-medical professionals, and look at the total patient. It is unique in that in most organizations there still is a separation between disorders of the mind, the domain of psychiatry, and disorders of the brain, usually falling to neurologists and neurosurgeons. We believe there's many benefits to this, including the destigmatization of mental health. But I mentioned earlier the fact that there's an intersection between many of these disorders. There's a relationship between depression and stroke and dementia, and only by taking all of it together will we get the best results. So we're doing it right now. So I'm now going to go to the innovation piece, Mr. Adler. We have actually built a significant program around focused ultrasound for treating disorders of the brain. This is a way of actually doing scalpelless surgery, of treating disorders inside the brain without actually cutting through the skull. We focused on initially disorders which are related to the brain diseases, and we focused on tremor and tumor. But we now are expanding this to disorders of the mind. We're going to be looking at opportunities to treat obsessive-compulsive disorders. We believe that by another application of ultrasound, we can break down the blood-brain barrier and get medications across and into the brain to treat depression and other disorders. So from our perspective, actually focusing on the total patient, bringing disorders of the brain and mind together will truly have impact, and as I hopefully have emphasized, it's happening today.
Now, you mentioned that you are doing it now. So if you're doing it now, why are you here? What are you asking for? Why the $30 million, and what do you plan to do with that $30 million?
So we are doing it now, but we have treated less than 10 patients with benign essential tremor. What we have identified is what we call a preclinical model for breaking down the blood-brain barrier, which means we're not yet doing that in humans. So we have the opportunity, by investing in infrastructure, to bring those individuals together in the same environment and get the synergy that we believe will actually help to change the future of disorders like dementia, like depression, for those across the entire country. So the infrastructure, the environment of bringing everyone together in one center is different than what exists in Vancouver. In Vancouver, it's more around research. This is research embedded in care, and we believe that that's the model that's going to result in the best return on investment.
And that is unique, right? That's not happening anywhere right now.
Right. So what I have described to you, the totality of the program, the focus that we have in research is not happening elsewhere.
Because our government has been funding, I mean, I'm thinking, you know, $100 million between 11 and 2017 for brain research. That is not what you're talking about, is it?
It is not. This is around an investment in infrastructure to bring all of those various individuals together, researchers, those who are treating clinically, then building the networking across the entire country to have that dementia strategy, that strategy for treating disorders of the brain and mind that doesn't exist right now.
Now, you mentioned that, thank you, $30 million. You had mentioned in your presentation private sector funding. Can you, so you're not here with your hand out simply asking for the government to fund a center for $30 million. You have matching private sector funding. Can you talk about that?
Right. So we are building on that right now. I anticipate by the end of this month we'll be in a position to announce a lead gift of $20 million against the 60. We have other donors who are incredibly interested in disorders of brain and mind. We see that as a great trend for the future at Sunnybrook and beyond. And so our commitment is to continue to work with our donors in order to raise at least 50% of the $60 million total.
Thank you very much.
Okay, thank you. Thank you, Mr. Adler. On behalf of the committee, I want to thank all of our witnesses for partaking in the pre-budget consultations. We appreciate your input very much. Colleagues, we'll suspend for a couple of minutes and bring our second panel forward. Meeting back to order. This is meeting number 46 of the Standing Committee on Finance. Colleagues, if I could have your attention, please. Thank you. Thank you. Thank you. Colleagues, please, if I could just have your attention. We are starting again with our second panel for today. We're very pleased to have our guests with us here. Thank you so much for being with us. We have, first of all, we have the Assembly of First Nations. We have the National Chief, Ghislain Picard. Est-ce que c'est correct, Ghislain Picard? Picard? Oui, bienvenue. We have the Canadian Federation of Students. We have Jessica McCormick. We have the Center for Drug Research and Development, the Chief Financial Officer, Ms. Catherine Hayashi.
Hello.
Hi there. We have the National Initiative for Eating Disorders. We have Mr. Bill Rogers. Welcome.
Thank you.
And we have a former colleague back. We have from the Partners for Mental Health, we have the Honourable Michael Kirby, former Senator. Founding Chairman, welcome back.
Good.
And welcome to the House Commons Committee on Finance. It's a pleasure to have all of you with us. You will each have 5 minutes maximum for your opening statement, and then we'll have questions from members. On va commencer avec,
We will begin with Mr. Picard, please, for 5 minutes. Thank you very much, Mr. Chairman.
Thank the committee for inviting us to appear today. My name is Ghislain Picard. I'm the National Chief of the Assembly of First Nations. The Assembly of First Nations is a national political advocacy organization for First Nation governments in Canada. I am joined today by my colleague, Manitoba Regional Chief Bill Travers, who is also the national portfolio holder on the AFN Executive for Housing and Infrastructure. The need for investment in First Nations will not be a surprise to this committee. The AFN has been raising chronic issues of underfunding directly to this committee as part of the pre-budget process for over a decade. Additionally, First Nations and other organizations have been bringing your attention to these urgent needs. This year alone, there were 67 submissions that had direct recommendations regarding First Nations. Chronic underinvestment in First Nation communities creates widespread and long-term impacts on all aspects of the economy. We have moved beyond having to prove that a disparity exists. The deep inadequacies in federal funding to First Nation in all areas, core operations, education, child welfare, infrastructure, and health, are known and accepted. However, what we lack is the clear political commitment to address these. Within this context, the AFN once again is put in the position where we are forced to advocate for continuing already inadequate funding, because even losing that would be untenable. When we look at the budget cycle for this year, there are a number of programs that support First Nations where funding is not currently identified beyond this fiscal year. This includes the Aboriginal Skills and Employment Strategy, a critical support for training First Nation citizens and creating linkages with employers. Also, numerous programs that support the health of First Nation citizens need to be continued in the next budget, including the Health Services Integration Fund, the Aboriginal Health Human Resources Initiative, the Aboriginal Diabetes Initiative, Maternal Child Health, and Children's Oral Health Initiative, and the National Aboriginal Youth Suicide Prevention Strategy. The specific investments required in the 2015 budget are outlined in AFN pre-budget submission. But we all know that we cannot continue with piecemeal, inadequate, and discretionary project-based funding. A fundamental transformation of the relationship between First Nations and Canada is required in order to achieve significant change for First Nations. New funding mechanisms are needed that move away from arbitrary and coercive contribution agreements to a fiscal mechanism that recognizes First Nations' title and rights. I would like to specifically refer to funding commitments made last year by the Prime Minister for First Nations education. Our children cannot continue to face inequities in education across Canada. The AFN has been directed to ensure these funds are provided to our communities immediately and to engage with Canada on a new financial framework on education that supports predictable and sustainable transfer payments to First Nations schools. I will turn to my colleague now to make brief remarks specific to infrastructure and welcome questions you may have. Thank you.
Welcome.
Thank you. Thank you, Miigwech. And good evening. Majigabon dis nikas. Makondudim. Good evening. I am here tonight to speak to you about the dire situation in First Nations communities related to housing and infrastructure. In Manitoba, we have 64 First Nations, and 31 of them are remote isolated. They rely on winter roads for access, for supplies, but with climate change, these are lasting for less time and are often, unreliable, unpredictable. There are substandard and deplorable housing conditions in First Nation communities. Recent environmental disasters affecting First Nation communities, such as flooding, especially the flood of 2011, and forest fires, have just made this worse in Manitoba. There are 2 First Nations that have been forced out of their communities due to floods and are facing great hardship in temporary housing or hotels in Winnipeg and other urban centres. They have been there for over 4 years now, and many of them are passing on, are dying. We are facing a housing crisis in our communities. The government knows this. A recent report identified that between 2010 and 2034, there will be a housing shortfall of 130,197 homes, and that an additional 11,855 homes are required to replace existing ones that are inadequate, and at least 10,000 need major repairs.
Okay, Chief Traverse, sorry, we are out of time. Can I get you to conclude your opening remarks, please?
Just like education, we need to move forward on a framework that respects and fulfills our treaty and inherent rights, and that responds to the real needs of our people. Miigwech, thank you.
Okay, thank you very much for your opening statements. We'll move now to Ms. McCormick, please.
Thank you. Good evening. My name is Jessica McCormick. I'm the National Chairperson of the Canadian Federation of Students. The Canadian Federation of Students is Canada's largest and oldest student organization, representing more than 600,000 students across the country. Our organization advocates for an accessible, affordable, high-quality public post-secondary education system. My presentation to the committee today comes at a time when students are facing significant hardships. Students are struggling to cover the increasing costs of a post-secondary education, an education that has become a prerequisite to participating in the workforce, and are graduating into a precarious labor market. More than ever, students are looking to the federal government to build on its long history of involvement in funding post-secondary education in Canada. For more than 60 years, Canadians have benefited from federal education funding, either through direct or indirect transfers to the provinces or from student loans and grants. It's this kind of national leadership that is critically needed to advance Canada's economy and reduce socioeconomic inequality. Our budget recommendations focus on making post-secondary education more affordable for students and ensuring graduates have access to good jobs. Throughout our lives, students have been told that we need some form of higher education in order to get a good job and participate in the workforce. However, rising tuition fees have made getting that education increasingly difficult. Across the country, educational choices are limited based on the region you live in or your socioeconomic background. Growing up in Cape Breton, Nova Scotia, I knew I had to get an education in order to get a good job, but my options were limited. I could stay at home and live with my parents and go to school in Cape Breton, or I could move to St. John's, Newfoundland and Labrador and attend Memorial University. Other public post-secondary institutions in Canada were completely out of reach for me. After we compared costs, my parents and I soon realized that it would actually be more affordable for me to leave home and go to school in Newfoundland and Labrador, where tuition fees are about half what they are in Nova Scotia. Ensuring that all students, regardless of which province they're living in, are able to pursue a higher education and get the training and skills they need to succeed must be part of any long-term economic strategy. While the federal government makes significant investments in education each year through the Canada Social Transfer to the provinces, there's no mechanism for accountability of these transfers. A dedicated transfer payment for post-secondary education would not only increase accountability, but also help establish long-term post-secondary education objectives that target quality and affordability. In return for upholding these principles, provincial governments would receive increased and predictable funding from the federal government. In 2008, the federal government answered our call for a national system of grants. However, high tuition fees erode this historic investment by forcing many students to borrow in order to finance their education. Each year, more than 450,000 students borrow through the Canada Student Loans Program. On top of that, an increasing number of students are enrolling in the Repayment Assistance Program because they're unable to make minimum monthly payments on their loans upon graduation. The long-term impacts of carrying student debt include delayed participation in the economy, the inability to invest or save for retirement, choosing to move out of the country to find work, starting a family later in life, and an aversion to taking financial risks. Increasing the value and number of non-repayable grants available to students could significantly reduce student debt in Canada. In Newfoundland and Labrador, the provincial government recently announced that they'd completely replaced the provincial loans program with grants. The expansion of the grants program in that province has greatly reduced student debt and is an example for the rest of the country. Young workers and recent graduates enter a labour force riddled with high youth unemployment, a characteristic experts agree harms our economy. Young Canadians are highly educated, however, many have difficulty getting a foot in the door in today's workforce. While investing in education is one of the primary vehicles for reducing youth unemployment, there are other areas that need attention. The precarious labour market means that many new graduates take on unpaid internships in order to gain relevant work experience. Although Canada does not track the numbers, it's estimated that there could be as many as 300 unpaid positions per year. More robust protections are required to safeguard interns, and increased enforcement is required to ensure employers who break these laws face consequences. While Canada is not the only country facing high youth unemployment challenges, there are lessons that could be learned from peer nations that could be successful here. One such model is the German dual system of vocational education. The system combines classroom-based academic learning at public colleges and universities with practical on-the-job vocational training. This model has a proven track record and contributes to Germany's low youth unemployment rate and one of the strongest labour markets in the world. Additionally, Germany's private sector plays a vital role in the system. Unlike many employers in Canada who have reduced on-the-job training over the years, employers in Germany are providing training that gives students applicable skills that help them advance within their job and are portable to other work. And I would be remiss if I didn't note that less than a decade after they were introduced, Germany recently eliminated tuition fees. So 5 minutes is never enough time to do justice to the recommendations that we've put forward for this year's budget, but more details and background research on our recommendations are provided in our written submission, and I'd be happy to take any of your questions. Thank you.
Okay, thank you very much for your presentation. We'll now go to Ms. Hayashi, please.
Good afternoon, ladies and gentlemen. On behalf of the Center for Drug Research and Development, CDRD, and our commercialization vehicle, CDRD Ventures, I'd like to sincerely thank you all for this opportunity to speak with you today. To firstly introduce our organization, headquartered in Vancouver, CDRD is Canada's National Drug Development and Commercialization Centre, the only one of its kind, providing the expertise and infrastructure to transform basic health research into commercialized therapeutics, improving human health, while at the same time growing our national health sciences industry into a fully optimized generator of economic prosperity. CDRD represents an effective means to advance innovative technologies forward along the innovation continuum, adding value throughout that process. These value-added technologies can then form the foundation of a critical mass of new health sciences companies, thus creating long-lasting, high-paying jobs for Canadian families and supporting continued Canadian brain gain by providing biomedical researchers with attractive opportunities in Canada. At the same time, training opportunities that generate new, industry-ready, highly qualified personnel to lead the industry into the future is also a key cornerstone for CDRD's success. CDRD-developed technologies also represent an opportunity to improve patient care while reducing healthcare costs through more effective treatments and frontline care for Canadian families. For example, better management of chronic diseases and subsequent reduced hospitalization. In terms of supporting families and helping vulnerable Canadians specifically, CDRD represents a new way to bring innovative therapeutics to patients, a national model that fosters collaboration, sharing of resources, leveraging of investments, and mitigation of risk. It also offers the opportunity to improve patient care while reducing healthcare costs through more effective treatments and frontline care. To further illustrate the potential impact on patients, I refer to our partnership with the Multiple Sclerosis Society of Canada, announced earlier this year. This partnership has been created with one goal in mind: to speed up the development of new treatments and find a cure for people living with MS. I'd like to cite a related passage by MS Canada's Vice President of Research, Dr. Karen Lee. She says, "When I look back over the years, I can recall a lot of great research that has been done to better understand, diagnose, and manage MS. Studies have been founded by the MS Society in addition to those which have been conducted around the world, and have changed the landscape of MS research in monumental ways. But the one thing that always seems to come up in any conversation with people with MS is that advancements in research still take a very long time, and they fear that they will not see the true benefits or impacts of research in their lifetime. This led to the establishment of a very important collaboration with an organization that not only has the tools and resources to speed up treatment delivery of MS, but is located right here in Canada, CDRD. Next week, we will in fact be announcing our very first drug development collaboration under this partnership, one that is very reflective of the strength of our model as it brings together a lead researcher from Memorial University in Newfoundland, CDRD's drug development and commercialization experts in Vancouver, clinical collaborators at the Montreal Neurological Institute, and global industry funding partners. To ensure Canadian families are provided with the best treatments and to further support this type of critical collaboration and CDRD's ongoing sustainability as a large-scale national endeavor, CDRD is therefore requesting a unique federal investment to support its next 5 years. This will provide the foundational support CDRD requires to ultimately reach the point of self-sustainability. The federal government has a tremendous opportunity to build on CDRD's success and further optimize what it has already helped to seed. We have established an international competitive advantage for Canada and now have the opportunity to leverage this advantage to realize the full potential of Canada's health sciences industry and improve the health of Canadian families while creating good jobs. In doing so, Canada will not only be the generator of world-class health research that it is today, but also be the generator of world-class innovation from the translation of research.
Okay, thank you very much for your presentation. We'll now hear from Mr. Rogers, please.
Thank you very much for letting us present today. I am a volunteer for the NEED organization. I'm here with my associate, Lauren Jono, She's a founding member of NEED, and she's a recovered eating disorder patient, and she also works with people with eating disorders. Who is NEED? NEED is a for-purpose, not-for-profit coalition of parents and children challenged by eating disorders, sufferers, healthcare professionals, and counselors. NEED's aim is to increase the awareness and education of eating disorders to promote change in the understanding, treatment, and funding of the disease in Canada. What does eating disorders mean? First of all, it's a disease that has one of the highest mortality rates of mental illness in the world, but it can be prevented and cured, which makes it unique. It is prevalent in young girls and women, but is expanding its presence to citizens from all walks of life. Recently, there was a 7-year-old boy admitted to Sick Children's Hospital in Toronto with eating disorders, all the way up to an 86-year-old woman who had had bulimia for over 30 years. The causes, the blunt reality is we don't know. There is lots of research, but there is no true cause. But what we do know, and it's more important than anything else, that it can be prevented if it's treated at an early stage. The number of eating disorder cases in this country continues to increase. There's very few data points on eating disorders. One of the more recent ones, and this was done in 2006, may be representative. Researchers in Edmonton studied 700 children in grades 5 to 7. 15% of these children were purging or over-exercising. 16% were binge eating, and 19% restricted themselves to 1 meal or less per day. Very, disturbing facts. How is it currently being treated? The only thing I can say is not well. The number of family doctors trained in treating eating disorders in Canada is almost nil. The community health care agencies lack both the time and the funding for training in eating disorders and are generally overwhelmed by mental health referrals. There's also a huge shortage of psychiatrists who specialize in this. Currently, there's 4,100 psychiatrists in Canada, of which 12 specialize in eating disorders. Of these 12, there's only a handful that specialize in treating children and adolescents where it's most prevalent. However, there are evidence-based programs that have been developed by researchers and doctors over the years that work. They've proven in test studies to work. However, there has been no funds and no initiatives to develop them among our healthcare system. So what do we need? In order to really beat this disease, and many doctors and researchers we've talked to believe it can be, we have to develop an infrastructure that can build the capacity for the delivery of timely, age-appropriate, evidence-based treatment and support services. These services have to span prevention, specialized outpatient treatment, intensive treatment, and residential services. We have to educate and train. We need to train family doctors to screen for eating disorders, to have the language to talk to our children about nutrition, body image, eating disorder thoughts, urges, and symptoms. We need to send more trained mental health nurses, healthcare counselors into our high schools to help young people who are struggling with these issues. So how do we get there? This disease we know is pervasive in Canada. There's no data that tells us how many people have it. However, the NEED phones ring off the hook. We're all volunteers. We fund it with our own money, and people and families looking for help. They're looking for help for their children, their loved ones, because so many of them end up dying as a result of this disease. Provincial healthcare systems typically need hard data to be able to allocate their scarce resources to this disease. Provincial healthcare systems inadvertently have developed they're charting systems, okay, to hide the data on ED. Not on purpose, it's just the way it's developed. For example, there's no charting category for eating disorders in any of the doctor's charts, which ultimately is being used for the data on many of the healthcare decisions that hospitals and healthcare administrations have to deal with.
Mr. Rogers, if I could have you conclude, please.
Sure. So in conclusion, we believe it's an insidious disease that can be prevented and cured, but today it continues to kill people. We would love your support to help us make the first step to get there.
Okay, thank you for your presentation. We'll now go to Senator Kirby, please.
Thank you very much, Mr. Chairman. I'm going to take the first 1 minute of my time. The clerk and I believe we have a way of showing you a short video, 30 seconds in English and 30 seconds in French. Since I didn't bring my grandchildren to make sure it was going to work, I'm relying on the clerk to try it. Go ahead. It's on your iPads, as I understand it. Oh, it's also up there. Okay. Thank you for that. I thought that would sort of set the scene for the rationale for my proposal. That, just as an aside, that particular public service announcement was played on at no cost to Partners for Mental Health. Indeed, we got the actual making of the 30-second piece contributed. We got $1 million last year worth of free publicity, according to the networks. The next PSA in terms of frequency of play got $100,000. So that piece obviously touched a lot of people in the media and people watching it. Let me just give you a couple of very simple facts about the issue of children and youth mental health. First, suicide. First of all, it's the second leading cause of death of people between the ages of 15 and 24, second only to car crashes. Among First Nations youth, it's four times the Canadian average. Canada is the third worst youth suicide percentage among all the industrialized nations of the world. More importantly, in many ways, 3 times more youth die by suicide than by all forms of cancer combined. And to put it perhaps in a very graphic way, over 750 young people kill themselves, which is the size of a mid-sized high school. And visually, if you think of a mid-sized high school being totally wiped out, it gives you some indication of the size of the problem. What I did was convene a team of experts from across the country under the chairmanship of Dr. Ian Mannion, who is the Executive Director of the Centre of Excellence for Children and Mental Health in Ontario. We developed a research proposal. I've given you the summary in the document of the methodology and so on. The fundamental thing to understand is that the methodology is to choose 25 communities across the country, communities that will be geographically dispersed but also be very culturally dispersed and different. So some will be First Nations, some will be Inuit, some will be multicultural, some will be rural. We need to understand what the characteristics of a community are to develop the best community-based way of dealing with the problem. Because the one thing we absolutely know is you cannot simply have a laying on of hands from the national or the provincial level and have a meaningful impact at the community level, it's got to be community-based, and it's got to be essentially a whole community-based in that it's got to involve people from education, from health, from justice, from child welfare, from families, and indeed from youth themselves. What I anticipate as an outcome is not dissimilar to the kinds of outcomes I got from the similar cross-country study that I did when I was running the Mental Health Commission, which in our homeless mentally ill study, where we determined what are the most important characteristics of delivering mental health services to the homeless, because we know approximately 80% of the homeless people have some element of a mental problem. We intend to do exactly the same kind of outcome geared to the particular makeup of a community. The final point is that we intend to do this with matching funds. I'm not interested in just getting federal money. We will get matching funds from provinces, from philanthropic organizations, from some private sector organizations, and so on. I've done enough conversations across the country now that I can say quite comfortably that we can raise that money, simply because everybody believes it's a paramount problem, and we've got to have an evidence-based approach to solving the problem. Finally, Mr. Chairman, I'd like to add one thing. Several senior members of the government have asked me to add on a component, so I'm in the process of doing that, which will also look at the issue of military suicide, in which the communities will be either military units or they will be bases, so that in a sense we will expand it from 25 communities to 30, with the other 5 being related to the military. And I guess, Mr. Chairman, my bottom line would be that this government has been exceedingly kind to me. They asked me to put together the Mental Health Commission, and we ran that. They asked me to run the program on the homeless mentally ill, and I'm now asking them to give me a chance to do one last very important thing, which is address the issue of youth suicide.
Okay, thank you. Thank you very much for that presentation. Colleagues, for the first round, the first 4 questioners will do 7-minute rounds, then we'll move to 5-minute rounds, because we do have a vote this evening, at least one. Ms. Davies for 7 minutes.
Thank you very much, Chair, and welcome to our witnesses. I'm not usually on this committee. I'm the health critic for the NDP, so I'm subbing in because there are a lot of health issues that are coming up today. So I do want to focus on that. And in particular, I'd like to just follow up with Grand Chief Picard. I know you raised a lot of issues, but if I could just focus in on the issues to do with health and wellness. I know that recently, finally, after many years of advocacy and lobbying, there is now a joint sort of study review of the non-insured health benefits, which is a federal responsibility. It just started recently after, I think, the AFN calling for it for years. And I just wonder if you could give us any update as to how that's going or what you hope the outcomes are. And secondly, very concerned to see the list of programs that are due to sunset in 2015. You know, they're all critical programs. I can't imagine what anxiety it causes to the organizations, just even worrying about whether or not they're going to be able to continue. So I just wonder if you could tell us a little bit more about the impact if there isn't any continued funding. I mean, I could name a couple. A major one would be the Aboriginal Diabetes Initiative, for example, which we heard about earlier. So if you could respond to that, and then I'd also like to ask Mr. Kirby a question if there's a couple of minutes left. So, Grand Chief, if you could talk about the non-insured health benefits partnership.
Well, on this issue, we certainly can follow up with the committee in terms of providing the information that you are requesting. But I think I want to take maybe just a few seconds to respond to the second part of your question, which is, to me, very key in terms of our role before this committee and our numerous attempts over the last 10 years to adequately represent exactly what you're speaking about. Because obviously, if the cost of health is rising, in Aboriginal communities. That's because the cost of other programs stays the same, housing, education. And to me, all of that has an impact on, on the health sector alone. And to me, we often find ourselves in this vicious cycle, which, is reflected to the last part of your question, which is, what happens beyond 2015? And certainly that creates a lot of uncertainty in our own institutions, in our own First Nation governments, not to count, I guess the tremendous turnaround in personnel. That also provides instability that we don't need, in many of the programs. So I think, like I said earlier, we respect, I don't want to be out of order, but I need to say this. We respect the, Parliament institutions, but at the same time, some of our people might not agree with this, because we come to these committees expressing what we feel are, totally disappointing, programs in terms of their impact for our communities, providing suggestion for change, but having very little result. And to me, this is what we take back to, our leadership.
Well, thank you, and I totally understand and respect where you're coming from, because it is about action and follow-up rather than just, empty promises. So certainly for the NDP, we're going to be pushing this and making sure that those commitments are made. If I could just turn to Mr. Kirby, certainly suicide prevention is a huge issue in this country, and it's good that there has been a fair amount of discussion in Parliament about this issue. We've had private members' bills, we've had sessions at the Health Committee. But I do want to ask you, the organization that you head up, Partners for Mental Health, I'd like to ask you, what is your record, not what you want to do, but what you've actually done in terms of collaboration with other key partners? Because frankly, I'm a bit surprised that you're here, I presume, asking for federal funds, because there are major players already doing this work, whether it's the Mental Health Commission of Canada or the Canadian Alliance for Mental Illness and Mental Health, Canadian Psychiatrists, Canadian Psychological Association. So it's not clear to me what your collaboration, what your record of collaboration is in working. I mean, I think it's very important that there not be duplication. And these, particularly the Mental Health Commission of Canada that you were involved in, I mean, they have a very significant ask in terms of continuing their work, which goes right across the country, and I know that suicide prevention is very much a part of their agenda. So what's your collaboration
Just
there?
a brief response, please.
The commission, Partners for Mental Health has been going for about 1.5 years. Our intent was, and still is, to build the kind of social movement that exists with breast cancer. We've already recruited 70,000 members and growing. There is none of the organizations you mentioned are doing anything on the ground to actually figure out how to make changes at the community level. They're doing lots, sort of what I would call paperwork.
Surprised to hear that. I've met with them, and I don't agree with you.
Well, they are not doing the kind of work, actual empirical work on the ground that is required to ultimately really make a difference. And I've always been...
What's your level of collaboration with them? What have you actually done to collaborate with those organizations?
Well, at this point, we haven't had anything to collaborate with them, because I've been out building a social movement, right? And none of them are into the business of building a social movement. We're the only people really doing really aggressive social marketing. So there really hasn't been anything.
And what are you actually asking of the federal government in terms of financial support?
I'm asking the federal government to do as it did with the homeless mentally ill, to contribute $100 million over 5 years to run projects in 25 different communities targeted specifically at finding out what really works. Not theoretical, but in fact in practice.
Thank you.
Okay, thank you. Thank you, Ms. Davies. We'll go to Mr. Saxton, please.
Thank you, Chair, and thanks for our witnesses, to our witnesses for being here today. My first questions will be for the Centre for Drug Research and Development. And Ms. Hayashi, I recently, as you know, had the opportunity to visit your very impressive facilities at the University of British Columbia and to see firsthand the work that you're doing there. Perhaps you could share with the committee some of the successes that CDRD has had to date and how CDRD is going to help Canada become a world leader in drug research.
We've had quite a good record so far. We are a relatively new organization. We were initially funded in 2007 by the province of BC and spent the first couple of years building labs and building up our team. But since then, we've got a couple of spin-out companies, one called Sitka Biopharma. They are working on a platform technology, but their initial application is for bladder cancer. There's not been a new treatment in bladder cancer in 30 years. It's the most expensive cancer to treat per patient over a lifetime because it's a recurring cancer that comes back and comes back. So this could be a new treatment paradigm for breast cancer with one treatment could resolve the disease enough that it wouldn't recur. So that's one of the things. And the platform also has other applications. It could also be used in prostate, other sorts of vesicle-type cancers. We also have a company called Kairos, which is an antibody drug platform, or antibody drug conjugate platform. It's a very exciting technology, very high interest in the investor community, spearheaded by a man called John Babcock, who left a very good job at a very large company to lead the initiatives of starting a company that he wants to see as the next Genentech in Canada. He wants it to be a successful company that runs, it's not acquired, and creates jobs and prosperity for Canada. He's had a high interest level from both angel investors and venture capital investors, so we'll see how that progresses. But it's a cutting edge platform of biologics that was initially funded through a grant through Western Economic Diversification to bring him aboard with a few staff and some startup equipment, and now we've got to a point where we've got a very exciting new company on board.
Okay, so in addition to research and development, you're also focused on incubation as well as commercialization of the drugs. Is that correct?
That's correct. So we have a search team, and we've kind of figured this out over the past several years of operating, that we have a search team of very experienced scientists with industry focus that go to our partner institutions across Canada. So all of the health research institutions are part of our network in Canada. They travel to Memorial University, to Dalhousie, and all across the country, looking at projects, speaking to investigators, and trying to figure out whether there's a commercially promising piece of research that they're working on, developing a project plan, and then once we have a project plan, we pull in our industry partners, and they all take a look at the plans and figure out which projects they wish to fund. So right from the very beginning, we've got external validation in terms of independent review of the science, and also some indication that there's some market pull, that there's some real interest in this technology as an investable and developable drug.
Okay, and you've asked for $153 million over 7 years, roughly $22 million a year. How do you intend to invest that money?
Actually, it's only $140 million.
Okay, well, even better.
And it's really to leverage what we've already started, but really to establish CDRD firmly as a national organization with an expanded search team that we can really have people on the ground all across the country, and also to really invest in some of the projects. Drug development is a very time-consuming and complicated process, and you have to expect a lot of attrition. It's science, so sometimes the experiments don't work out. So you need a lot of shots on goal to find the successes that will provide not only the economic success at the time, but the self-sustaining aspect, which we've built into our model right from the beginning. We realize that we have this startup period where we can invest in technologies, and hopefully there'll be a couple of home runs in there that will fund our continued operations after our startup period.
Thank you very much. My next question is for the National Initiative for Eating Disorders. In your submission, you propose a ministerial advisory committee. What role would a ministerial advisory committee potentially play in drafting and implementing a national strategy on eating disorders?
That's a good question. As a small organization, a relatively new one, we recognize that any funding for this research should fall under some sort of a federal organization to oversee it. We believe that, in going out into the marketplace, we've got two things that has to be done. First of all, we've got to look at all the data that's being collected, and there's a bunch of little studies here and there, and determine how to get at that data. And a national, organization undertaking this will have much easier access to obtaining that data, and we'll be able to manage the funds. We don't propose to do this ourselves. We're not set up to do it. It's not what we want to do. What we see is we need one of these organizations to take this on so the data becomes available nationally to the provincial governments, the federal governments, so that we can start building an action plan to move this forward.
Thank you very much. My next question is for Michael Kirby with the Partners for Mental Health, very quickly. What strategies can be used? First of all, that was a very powerful ad that you showed us, so I think you've got a very good team making those. What strategies can be used to lower youth suicides in Canada?
The evidence from elsewhere in the world, hasn't been done in Canada, is that you have to do, as I said, a whole community approach, which means all of government services, but a number of private sector services, volunteer services. You've essentially got to get them all coordinated and working together, and that if you don't do a whole, essentially a full service group working together, it won't work. The second thing you got to do is you've got to have a significant role for youth in designing the actual program. What the evidence elsewhere shows very clearly is that coming in and the laying on of hands by some group of adults, whether they're local or not local, doesn't work. The kids don't buy it. And the best examples in the world, one in Germany, a couple elsewhere in Australia, have been in a case where not that the youth were running it, but they were a very major player, and that all of the various, both public, i.e. government, social services, and private sector, typically not-for-profits, social services get together.
Thank you. Thank you very much, Mr. Saxton. Mr. Bryson, if you're around.
Thank you, Mr. Chair. I'll start with Chief Picard. Chief Picard, what would be the Aboriginal versus non-Aboriginal school funding gap today? We hear from various witnesses that there's a significant funding gap, but what would be the funding gap today? Is it what percentage of non-Aboriginal school funding?
Yeah, well, the figures that come to my mind are that roughly an Aboriginal student costs maybe half than a non-Aboriginal student. But I think this also speaks to the issue of what happens in other programs as well. I could easily tell you that in Canada, tomorrow morning, we need 60,000 new units in housing in order to meet, the current rate, the Canadian rate of occupancy. And I could easily tell you that, there needs to be a look at, the escalators, the annual escalators when it comes to provinces versus that of, First Nation communities, which has been capped at 2% for the last almost 20 years now. And the same principle applies in education. It hasn't been reviewed, and we fall into this cycle of, coming to these committees and making our points.
So on a per student basis, schools in Aboriginal First Nations communities receive 50% of the funding of non-Aboriginal ones.
Yeah, well, it all depends.
A specific question, though. In your written submission, you call for money that was set aside in budget 2014 for First Nations education to be released immediately. Why has the government delayed this funding?
Well, to us, it's obviously tied to, our position in with regards to Bill C-33, First Nation control of First Nation education, and that's been really what I would call the dialogue of the death since the spring, in the sense that there has been no communication whatsoever, except our expressing our interest to engage government based on terms that we could also define as First Nations.
Senator Kirby, thank you for your work broadly on mental health, but your latest initiative. Given that we have the youngest and fastest growing population in Canada's Aboriginal and First Nations youth, given that you were saying that it's 4 times the rate of suicide in these communities, would that not be in some ways the lowest hanging fruit to focus on that one area where the federal government has a greater level of responsibility in terms of those communities, and focus on fixing that incredibly severe social crisis?
Yeah, look, I absolutely agree with your evaluation. It's scandalous. And I actually thought about doing that. But the more I thought about it, the more I realized that if you were going to get broad support for it, you really had to go beyond First Nations. I include Inuit, and both, because it's not as bad as First Nations, but it's not good. That you had to go beyond First Nations and Inuit. And as I said, a primary focus will be First Nations and Inuit, but you have to include the rest of the population as well. That, I guess I would describe that as a pragmatic conclusion to trying to make progress on the issue.
So in some ways, working in non-Aboriginal, non-First Nations communities in terms of the initiative helps build a broader coalition of support from the public for the initiative. That
extremely, yeah, and we know that. We know it does that.
Yeah, the whole issue around the stigma around mental health issues, and I know organizations like CAMH have done a good job in breaking down some of that stigma. How important is that part of your work in terms of reaching out to and changing people's minds, particularly young Canadians, about the stigma around mental health?
Addressing the stigma issue, which now a lot of people are doing. I mean, it sort of began when the Senate report came out and has escalated over the 10 years since then. But just attacking awareness for stigma is not going to solve the problem with the individual children and youth that have a problem. So the beauty of Take the Bell, Let's Talk campaign, the beauty of that campaign is that it's increased public awareness. But in the end, what you've got to do is take that increased sense of public awareness and say, okay, now what are we going to do about the problem? Because awareness doesn't solve the problem. And I've always been on the let's solve the problem end of the business, so for which this is a logical step to go. It would be much harder to do this if the public wasn't nearly as aware of mental health as they are now.
Yeah. If we, thank you very much for your work on this. Ms. McCormick from the CFS, you've spoken of the challenges in terms of affordability of post-secondary education and of the youth job situation and the unpaid internships. Stats Canada currently does not track unpaid internships. We know anecdotally that it's an issue that's grown. Would that be the best starting point, that Stats Canada actually commence the tracking of unpaid internships in Canada?
Yes, we appeared before the committee and spoke about this on a study on youth unemployment, about the need to track those statistics, just to get a good idea of what it is that we're dealing with, because we only have estimates that there are as many as 300,000. That's a good place to start, and we're lobbying provincial governments to enforce provincial legislation around the issue as well.
Okay, very briefly.
Just Mr. Rogers and some of the work, Senator Kirby, some of the work, I think there may be some opportunities, particularly around eating disorders in young people, for some collaboration. You may have some thoughts on that in terms of collaboration.
Okay, we're right up against the end of Mr. Bryson's time. Do you want to make a brief comment, Mr. Rogers?
Sure, absolutely. We've brought Michael and his organization into where we're at, and it's just another cause of suicide among children as well as death.
Yeah, we've talked about that explicitly.
Okay, thank you. Thank you, Mr. Bryson. We'll go to Mr. Keddy, please.
Welcome to our witnesses. To Grand Chief Picard, the ongoing investment in First Nations education, you're asking for an immediate release in your budget ask of the $1.9 billion for First Nations education. And at the same time, you know, your organization were involved in the drafting of this. I'm not quite certain what has happened. There seems to be toing and froing over the dollars. It's budget 2014. But we have to find a way to make sure that money goes out to First Nations. I don't think there's any argument at the table on any side of the table here that happen. But how do we do that, and how do we make sure that there's an equal level of expertise in all the First Nations involved in First Nations education, and how do we distribute those dollars in partnership? Because the one thing you heard at this table is partnership and collaboration and best practices, and that's the one word that I've not heard from you, so you need to enlighten me.
Well, what you're raising is exactly what, you know, we're hoping to achieve. We're seeking an arrangement or a framework, if you will, with the government in terms of how to best expand, you know, the monies that are needed. And obviously, we'll have maybe as many interpretations or as we have people around this table in terms of what happened over the last 6 months. But this doesn't change the fact that this money is needed for many reasons, including the fact that First Nations citizens across the country experience demographics that no other Canadian citizen or society experiences. So, I mean, right there is a good point, and the point made earlier about, you know, the discrepancies between what is available to First Nation communities versus what is available elsewhere is another argument I think that needs to be considered. And the fact that you know, the funding formulas have not been revised for the last 20 years as well is a good point to be made. And to us, let's discuss that. Let's find a, you know, an arrangement on this. And let's look at a much broader fiscal framework where, you know, First Nations leadership would find, you know, I guess some benefits.
Okay. Thank you for that. Recently, we had a group prepared to committee called Inspire, and they're doing some great work with Aboriginal students. They're achieving some great high standards at post-secondary institutions, both at the community college level and at the university level. And they've been able to leverage federal funding, fairly modest federal funding compared to what we're talking about, but still leverage federal funding into more scholarships. And they've been able to work with the private sector as well. So 2 questions. I assume you're familiar with the group, but can we find that same ability? And again, I want to use the words of collaboration, partnerships, and best practices to you know, access those funds and move forward.
Well, certainly, you know, no one will, I think, dispute what Inspire has been able to achieve, you know, across the country. But at the same time, and we totally agree with the argument that they defend as well, if you're going to be caught in a situation where you have to negotiate year after year what you plan for the next 10 years, it's never a comfortable situation. And to us, we certainly, you know, support that principle as well. And this is where most First Nation communities find themselves in, as raised earlier, you know, where you can plan for the next 12 months instead of the next 12 years. This is a situation that many of our communities find themselves in.
Thank you. To Ms. McCormick, you talked a little bit in your presentation, in your draft, on the German model. And we've had some great discussion about the German model around this table, and the success that it's had, quite frankly, and the buy-in from everybody, from the educational institutions to private sector to society. And it truly is a remarkable model. And whether the German or the Swiss model is first and second in the world, both of them are great. In their submission, you asked the federal government create a Post-Secondary Education Act in cooperation with the provinces with a dedicated cash transfer modeled after the Canada Health Transfer. Like that's a big ask. So, but you know, how much do you foresee that transfer being? How many students would that affect? And would it be all, again, would it be all federal dollars, or would there be some private sector partnerships?
Right. It's a big question. We talked about both the dedicated transfer payment in the recommendation. One of the main reasons why we bring it up is because it allows for a level of accountability for investments that are being made in the provinces. Whatever arrangement is made, and this is very much similar to the German model where there's a lot of cooperation between the federal government and the states, it needs to be something that's developed in cooperation with the provinces, because similarly here, you know, provinces have provincial, it's jurisdiction over post-secondary education. The specifics of the number of students that would be that would benefit, I don't have that number. We can come back to the committee and provide it in more detail. But I think whatever the arrangement is, similar to Germany, it's that there's cooperation between provincial governments and a level of accountability for the investments that are being made by the federal government.
If you could get those numbers back to the committee, that would be appreciated. Sure. And finally, because I just have to ask this question, the National Initiative for Eating Disorders, the you know, one of the highest mortality rates of mental illness for 7 minutes is up in the world is an outstanding statistic. So I don't know how you deal with that, because I'm out of time.
If I could have helped my neighbor in Nova Scotia, I would have. Okay, Monsieur Caron, c'est votre tour, 5 minutes.
Merci beaucoup. Merci.
Thank you very much, and thank you to all of you. I would like to each of you a question, but I'm only limited to 5 minutes. So welcome to the committee. I have a question for Mr. Travers. I know that there was a ceiling of 2% in social health transfers, and it's been like this for 18 years, and you said in your brief that the average increase for transfers was 6% from Ottawa to the provinces. You also said that the shortfall due to the ceiling was $3 billion since 1996. This $3 billion, is this based on the cost of living, or does it also reflect the demographic increase amongst the Aboriginal population? Yes, well, those two arguments do support our numbers, because the demographic growth amongst Aboriginals is unequaled across the country. So it's very important to take into account those realities. However, if we do not invest in housing, this is going to have an impact on education and healthcare costs. So these costs could potentially increase twice or 3 times. There is talk of infrastructure in Manitoba, especially in northern Manitoba. There is a problem with regard to Aboriginal housing across the country. Attawapiskat comes to mind. The Innu community in northern Quebec has the same type of problem. Coming back to 2011, there was a crisis in Attawapiskat, and we know that this housing crisis exists in other Aboriginal communities. What progress do you think has been made since 2011, since Aboriginal infrastructure made headlines? Well, you raised this issue, and it is in fact directly connected to the argument I was making earlier, namely what is available to provinces and what is available to our communities, and the fact that there's been a cap for the last 20 years. in terms of what is being invested in infrastructure. The other reality is that since the budget is already so tight, in fact, it's been tight for 20 years, this means that year after year, sometimes monies are shifted elsewhere. So money which normally would go to infrastructure goes to other sectors such as healthcare or social programs. As a result, housing needs would have gone up by a factor of 5 or 7 in certain areas. You said that there is a broken relationship between the federal government and Aboriginal communities, but you have had talks with the federal government in the past. What is the justification for capping transfers to Aboriginal communities by 2%? What argument is the federal government using to defend its position? Well, we would like to have the answer to that question, but beyond that, I believe that this situation could be the basis for perhaps better frame the relationship between Aboriginal communities and the federal government. With all due respect to the various organizations which have made presentations, submissions before this committee, I believe that any framework involving Aboriginals is very different and requires a more holistic approach. Thank you. I also have a question on murdered and missing Aboriginal women. The debate is ongoing. The opposition parties have asked questions of the federal government, which said that it will invest $25 million over 5 years to look into this issue. Do you think that response is adequate? No, we don't think so. However, if there was a commission of inquiry into why women have been murdered or gone missing across the country, perhaps we could better assess the needs of Aboriginal communities. Thank you. Thank you, Mr. Caron.
Well, thank you, Chair. Thank you all for being here this afternoon. I do want to pursue my line of questioning with Mr. Rogers. Portia de Rossi, Lindsay Lohan, Snooki, I mean, there's celebrity after celebrity after celebrity, high-profile people who've suffered from eating disorders. Everybody knows somebody with an eating disorder. Yet, why is there so much ignorance about eating disorders? Why do people who don't understand just say, well, all you have to do is eat some more and you'll be fine? Just eat a big meal and you'll be fine. Why are there only 4,100 psychiatrists who specialize in eating disorders? Why are there so few resources committed to the treatment of eating disorders in Canada?
It's an excellent question and one I've asked myself many times. I think it comes down to, and we've looked at it, and you know, everyone has an experience, but what we don't have, because what I talked earlier, things like the charting that goes on in hospitals. I'll give you another example. For example, when a child or an adolescent goes into the hospital with a severe eating disorder issue and they need to be hospitalized, they have to put them under a different category in order to allow the hospital to admit them to the hospital for the number of days it's going to take. So the eating disorder has been hidden under other mental categories for so many years. There is just no data. So when you go and you talk to administrators, provincial regulators around this, they know the problem's there. Everyone knows it's there, but it's very difficult for people with scarce budgets and limited time to be able to allocate on the basis of what they think they know. So it's our view, if we can get this data out into the public, okay, in front of the regulators, both federally and provincially, okay, it will impel them to start investing the time and the money into these programs to save the poor patients that are suffering with this disease.
Now, this is a widespread issue. I mean, this is not just in the health community. This has I mean, the police get involved, so it's, you know, there's criminal justice. This is just widespread. So it's not just, you know, educating people to identify eating disorders. It's much more than that. Can you talk about that?
Sure, happy to do that. Twofold. I mean, they're a big burden in the healthcare system. There's no question about it because it's continual. If we can prevent it and cure it, we can keep them out of hospital. The second thing that happens is, you know, particularly youth, you'll find them, you know, being picked up for stealing, all kinds of criminal activities that leads to it because they're hungry, parents don't want them to eat, so they go out and steal. So we have that burden. We also have the burden of the families, which is a huge economic problem. You know, we see families all the time. These are parents that lose their jobs because they're afraid to leave because their kids are so sick and there's no place to take them. There's no program to help them. And so they have to stay home in order, they're worried about suicide, issues like that. And, you know, it's a huge economic burden. We don't know what the data is, but I can tell you, phones ring off the hook at need for people looking for help because there just is none in this country. And we believe if we can get the data together and we can get that out there, we can make a huge difference in this disease and actually do something that's preventable and we can cure it.
I mean, it's pretty fundamental. I mean, needs to get funding in order to compile this data because, you know, when people die of an eating disorder, it's not registered that they died of an eating disorder. It's heart failure, it's liver failure, it's whatever. So we don't know how many people out there have, we know it's a lot of people, but we don't know how many people actually have eating disorders, do we?
That's correct. We do not.
Which is an abomination.
It is. Absolutely it is. It is, and it's fallen under the radar of our healthcare systems for too many years.
In terms of the treatment of eating disorders, well, let me step back for a second. You're not here asking for money for yourself or need to conduct this study, are you?
No, we're not. What we're asking for is the money to be put into, you know, it could be a number of agencies, but, you know, it could be someone like, excuse me, the Public Health Agency of Canada to actually conduct this survey. We want the data. We don't have to do it. We're not prepared to do it, but we need the data, and we need the allocation of the funds to do it.
And then step two is...
Thank you.
Okay.
Thank you. Thank you very much, Mr. Adler. We'll go to Mr. Rankin, please. 5 minutes.
Yes, thanks, Chair. Thank you, all witnesses. I'd like to start with Jessica McCormick, if I could, Canadian Federation of Students. I was taken with your excellent brief, and one of the recommendations that I wanted you to elaborate on, there's a few I'd like to have you elaborate on, but the one that I'm thinking of is the one where you talk about implementing a federal post-secondary education act in cooperation with the provinces, modeled after the Canada Health Act. And I'm wondering if you think that would do the trick, given that the federal government has not exactly been aggressive in enforcing the Canada Health Act. Why would you have any more confidence that they would do so if there were a post-secondary act like that?
Well, Canada is one of the only OECD countries that doesn't have a national Ministry of Education. And the situation right now in Canada is that there's a significant disparity in the tuition fees that are charged from province to province. It's a situation where students in Newfoundland and Labrador pay about $2,600 per year in tuition fees, whereas students in Ontario pay more than $7,000 per year in tuition fees. So the goal behind implementing a post-secondary education act is to provide some sort of consistency across the country and level standard of access to post-secondary education, and to provide some accountability for transfer payments made to the provinces to ensure that they're being invested as they were intended to be invested, rather than the situation that we have now, where money is going to the provinces through the Canada Social Transfer, but it's oftentimes unclear whether or not that money is being spent as it was intended.
You mentioned, I think, in your presentation just now that in Newfoundland and Labrador that the government has replaced the loan program with an entirely grants program. and you're advocating that be done on a national basis, or that other provinces use the transfer in order to do the same thing?
In both cases. It's something that we're advocating that provincial governments do with provincial student loans, but we're also advocating for an expansion of the national grants program that was introduced in 2008. In Newfoundland and Labrador, it's been progressively expanded over the years, and it was just this year recently announced that they would fully expand the grants program to replace the provincial student loans.
Any costing information as to what that might cost?
I can provide the costing. The information that we have in our submission is to reallocate some of the money currently invested in registered education savings plans and tax credits into the Canada Student Grants Program, because we currently invest about $2.5 billion per year in those programs.
Talking in your brief about First Nations and Inuit students and their post-secondary student support program, you are asking for the cap in the increase that was implemented in the 1990s to be removed. Is that essentially it?
Yes, in 1996 there was a 2% cap placed on increases to the post-secondary student support program, but as we've already discussed at the committee, the population growth of First Nations and Inuit students far exceeds other demographics, and so there are more students that want to access funding through that program, but because of the cap are unable to access the funding.
Well, in fact, your statistic was shocking. You say that between 2006 and 2011, over 18,500 people were denied funding, roughly half of those who were qualified because of that problem.
Correct.
Okay. Grand Chief Picard, sir, you mentioned in your brief skills training and the need for new investments. I think you've suggested $500 million annually over 5 years are needed to support that program. And then you reference that you suggest that the government implement the recommendations made in the May report of the Standing Committee on Human Resources and Skills Development, that there be a renewal of the Aboriginal Skills Employment and Training strategy for an additional 5 years.
1 minute.
Is what you're suggesting that the new investments of $500 million over 5 years be done sort of under the umbrella of that strategy? Is that what you're getting at there?
Yes. Well, I think what is important here is to, again, to create some level of certainty in terms of, what we should be planning for the next 5 years. I was part of the, original program back in '95, and the negotiations we held at the time provided us with a program that went, far beyond the, 3-year period. We had a 5-year program. That certainly makes for easier planning than what we have today, where, we just not unsure as to what will happen next year and the following year.
Particularly poignant given the demographics of First Nation communities and the number of children that are coming along and will need education and training in the future.
Well, I think that proof needs not to be made anymore. Yeah. It's evident right across the country.
Agreed. Well, thank you, sir.
Thank you. Thank you, Mr. Rankin. Colleagues, we have 2 members' rounds left with questions, 5 minutes each. We are going to, if we fill that, go 5 minutes into bells. It's 15-minute bells. Do I have your consent to do that? Okay, thank you. We'll go to Mr. Allen first, please.
Thank you very much, Mr. Chair. And does that mean I'm going to get a full 5-minute round or not? I'm going to share.
Well, apparently you're sharing with Mr. Van Kesteren.
I'm going to share with Mr. Van Kesteren. So I got a quick question to ask Mr. Rogers. I had a chance to meet with a couple of people, Alison Giberson and Kelly Beveridge, in my riding in western New Brunswick, who are actually intervening in an eating disorder program. And it was an interesting meeting that we had. Very informative, and I didn't personally realize some of the challenges, and as you said, a lot of young women and girls tend to be the most impacted by this. And one of the things that they talked about, and they're starting to get some numbers around, is repeat, where these young girls and women have to go back to the hospital. Repeat visits, repeat visits, repeat visits. With their intervention, they're actually starting to cut that down. And when I was talking with Maureen O'Neill for the Canadian Foundation of Healthcare Improvement last session, I talked to them about how we can save money in our healthcare system as opposed to necessarily just spending more money. So what I'd like to ask is there been any work, and do you know of where you have some of these cost-saving numbers that we could actually use to justify an investment in this?
There's limited data to the best of my knowledge. I can ask some of the consultants and physicians who have been active in this, if there are any. To the best of my knowledge, there are not, but there are places like in London, Ontario, London Health Sciences has a very large eating disorder program. Ontario, I know, has a $30 million program in various hospitals. And when I've talked to the physicians there, mostly they're outreach programs, but they work. And, you know, it gets people back on side. For example, my colleague here, Lauren, you know, she recovered. She had it when she was 18 and she recovered in her 30s. And it never leaves you, but now she knows how to deal with it. And that's where the programs come down to. They allow you to go through your life without having to, you know, be an anorexia or a binge eater or whatever. So I wish I had more data, but I think it's, but we will check and get back to the committee.
Appreciate that. Mr.
Thank you, Chair. How many minutes do I have, Chair?
Well, there's about 6.5 minutes for you and I. So.
All right. Okay. I want to go to you. He really puts the pressure on. I want to go to you, Grand Chief, and I appreciate you coming down here, and I thank you for your words. And it was brought up, my colleague member mentioned Inspire, but would you agree, and we're talking about the testimony of Mr. Kirby too, that so many of the problems that you experience, your young people need jobs. There's some great opportunities for them. Wouldn't you agree that that is probably the greatest need that your young people have at this point?
Well, they also need to be prepared to take on jobs.
Yeah.
And to me, that's where, you know,
But,
I guess education falls in place.
Ultimately, so that they can enter the workshop. So I want you, just maybe if you can tell this committee if there's a way that you could help us, because the testimony by Inspire, it was a great success story, but the problem is that most of the young people that are trained and graduate don't go into the private sector. Can you help this committee maybe just give some advice where the government might be able to enact something so that we can see more young people going into the private sector? Because we know that there are so many opportunities for your people, especially up north in the mining areas.
Well, I would say that the reality is that I think if provided with more opportunities, that certainly would happen more in our communities. But the other reality is also that we're facing a situation where we have a lot of catching up to do. And it certainly doesn't happen overnight.
No.
And to us, given the opportunities to, I guess, provide a quality education as it exists anywhere else in the country, it would be very key.
Maybe I'm not making myself clear. What I mean is that many of your young people that are graduating, as a matter of fact, I heard terms up to 85% are working in the community, which is a great thing. We're not discouraging from working in the community, but there are so many opportunities and great opportunities that would help First Nations peoples if they would go into the private sector and those jobs. How can we encourage them to move into that sector as opposed to into the other sector?
Well, our young people have that choice now, but at the same time, it certainly would fall, I would say, in the objectives of this government that we reinforce the governance in our communities as well. So to me, you know, it also speaks to that objective, you know, for First Nation governments to reinforce, you know, their own governance structures.
Okay, thank you. Thank you, Mr. Van Kesteren. I have a number of questions. I'll try to get through some of them. Ms. Hayashi, I wanted to start with you. I enjoyed your presentation very much, and in your submission, you talk about the support for networks of centers of excellence for commercialization research. You talk about CIHR, and then you state, there remains, however, a key gap in our ability to translate this world-class research into its commercial potential and realize the full extent of resulting economic and societal benefits. And I think that was probably a consensus around the time of this government's science and technology strategy back in 2007. But you do hear from people, researchers, others, who say that somehow we've focused too much on commercialization of research at the expense of funding for basic research. And I just wanted you to address that concern that some researchers are raising.
I mean, there clearly always has to be a balance. There can be no later stage projects if there is no early stage research. So absolutely there's an ecosystem of innovation in the healthcare system where you must have basic research, but hopefully the best, most commercializable aspects of that basic research can be found and focused upon and developed quickly, cost effectively through organizations like CDRD.
And then can I ask, in our first panel, Mr. Saxon asked some questions about ensuring that we focus health research dollars in a way, and trying not to sort of create so many different pots of funds, but ensure these groups collaborate together. One of the concerns that some people may raise is we fund a lot through Canadian Institute of Health Research, and the government should focus on funneling money there. In terms of funding commercialization, though, that's perhaps not the best vehicle, so that's why we have things like networks of centers of excellence. But it does lead to the question of ensuring that we're not just funding 1,000 different pots and we're not actually getting commercialization or value for dollar, or the researchers who are working are not accessing enough funds to commercialize their research. So is the networks of centers of excellence the model for doing that? What's the best way for the government to do that?
We've had a lot of success, and it's been an excellent program for us to start with. So we were one of the original cohort of Centers of Excellence for Commercialization and Research. We were successfully renewed in that program, but we have outgrown those types of programs. And I think in the previous session, there was a lot of discussion about, how can we as a government, how can we as Canada do this better? And an organization like CDRD that has a national focus and is about bringing together the right people in the right regional centers. So, for example, we don't want to build everything at CDRD. We need to leverage what's already been built and already been built successfully. So at Dalhousie, we have our zebrafish node. So the CDRD zebrafish node, which is a very interesting, cutting-edge, global leading center for it's basically zebrafish are little transparent fish where you can see their insides. So you can see how a drug is working without killing the fish, or you can just see them swimming around and you can test on them. So there's a researcher at Dalhousie that has a world-class zebrafish node, and we have a relationship with him so that we can use their resources, their expertise, so that researchers all across the country can benefit from that.
But from a policy point of view, is it better for the government then to fund a number of initiatives like yours across the country and pick them directly, or is it better to fund a program, if it's not the networks of centers of excellence, if it's something in addition to that, is it better to fund the program that funds organizations like yours, or is it better to directly fund right from the government?
Well, we think that we've reached a level that we are the National Center for Drug Development and Commercialization. So we have, over the past 7 years, worked very hard to develop a national network. We feel that we have outgrown federal programs, and we really are seeking now a foundational funding that would allow us to operate through our next period to sort of build up to the critical mass of being able to deliver as a national resource.
My last question would be then, so you'd almost have the government establish that criteria by which an organization such as yours meets all those criteria, moves beyond the networks of centers of excellence, and then gets funded directly.
Yes.
Okay, I'm very sorry my time is up here, and I impose it on others, so I'll impose it on myself. I want to thank all of you very much. Merci beaucoup à tous pour votre présentation.
Thanks to all of you for your presentations.
All the members get it. Thank you so much.